Okay, I think just so we can kind of hit it, let's do it. Just everybody, welcome. We have to, in order to run this virtually, have taken the step, which I think is the most successful way to run a virtual meeting so there's no AV issues, is everything is pre-recorded, and then the panel sessions will be live and interactive. So thank you to everybody for doing that. And I just think kind of for the sake of time, Aileen and Nicole, you've got the show. Why don't you guys run it and we'll go from there. I think I'm missing volume. Can anybody else hear the volume? We might be having AV issues despite pre-recorded.
No, I can't hear it either.
Hold on.
On behalf of the entire QC and myself.
There we go. That was it.
Okay,
You got it.
let's try this again.
Well, hello, everybody. My name is Mike Rosen. I want to welcome you all to our virtual 2021 Quality Improvement Summit. Obviously, I wish we could all be doing this in person this year, but as we get into the tail end of COVID, that's just not been possible. But hopefully next year, we'll be able to do this in person. But regardless, I think you guys are in for a great session today. I think we have a lot of exciting, impactful talks that are really going to change your practice. On behalf of the entire QC and myself and Ben, we look forward to a great session today. And again, thank you all for being a part of this. And I just want to specifically point out all of our stakeholders. I can't stress enough that we could not do this without everybody on this list. You all have a special role in this. And I hope you all take the same pride that I do in looking at what we've accomplished and how far we are actually moving the dial in hernia surgery and abdominal core health. I also just want to take a second and specifically recognize our foundation partners. We could not do this without your support. I realize this year with COVID has been particularly tough for everybody, including industry. And again, I want to thank you all for this. I hope you share in the pride that I do in looking at today of how far we've moved hernia surgery and where we can actually go through this type of collaboration. So just briefly, I think it's important sometimes for everybody to step back and look 8 years later at actually what we have accomplished. We have over 450 surgeons who are involved now throughout the entire United States. We're actually in almost all 50 states. And I think one of the things that I am most excited about is we represent fairly close to the real world in hernia surgery, where we have about 50% academic and 50% private practice and community affiliated surgeons. And I think as you see in the talks today, you will actually be able to appreciate that that is about the ratio in our talks, and really that shows a contribution and the fact that everybody does have an important voice in this collaborative. Again, we surpassed a huge milestone this month. We have over 75,000 patients in the ACHQC now, which is just really a tremendous effort over the past 8 years. We still are about 2/3 ventral hernias, but inguinal hernias are rapidly increasing. It's certainly a more common operation, particularly done in the community setting. I also want to just stress this year we've had the addition of 7 key ACHQC committees. Please take a second and think of any of these, including our data integration to streamline surgeon enter data by Clayton Petro and Jeremy Warren, our research committee looking to design all of our clinical trials by Richard Pierce. If you have any residents and fellows that would like to get involved, I think this is a huge first step in joining the collaborative early and seeing the benefit. Again, one of the most exciting groups that we have is our patient engagement and advocacy committee, led by Harriet Schwartzman and Eric Beauford. And again, some of those patients are on the call today, so thank you very much for all that you've done. Our quality improvement committee, led by Ragnar Peterson, has been instrumental in coming up with some of the topics today. And then our membership and surgeon outreach committee that has been led by Todd Harris and David Capata. They will start off the next section. And again, they put a tremendous amount of work into trying to understand what our surgeons' needs are and how to make things better. And then Mickey Reinhorn, who's led the opioid task force, that has just done tremendous work that has really personally changed my practice tremendously. So just briefly, the agenda today, we're going to start off with the data input and utilization optimization. We're going to hear from different practice groups and how they've been able to optimize entering data into the collaborative. I would tell you this is probably the most common question that I get when people start out is how do I incorporate this into my practice? And we're going to really learn from some of our high performers. And then we're going to move on and learn from our high performers, specifically inguinal hernia approaches and ventral, incisional, and peristomal. I think this is actually the most exciting aspect of the QC, because here we are actually identifying people who really do these procedures in a high volume. And this doesn't necessarily mean the folks who write the most papers or whatnot. These are the people who really do this. And I think this is the most impactful thing when we did this before. So I really look forward to hearing some great talks around this as well. Again, one of the things that makes the collaborative important, in particular our QI Summit, is engagement. So please engage in the discussion. I realize this is virtual and it can be a little bit more challenging, but use the chat rooms that you can ask questions. The moderators will be looking at those and they will bring those up during the panel sessions. I think that will make things flow the best way through this in a virtual way to move through each of the talks and sessions and get the most of your questions answered. We'll also have a poll opportunity that we have some pre-done polls that you can click on your keyboard and answer those. And we'll see the results. And we'll give you an example of that just at the end of my talk here. So just kind of to summarize, my goal for today is to make an impact in your practice. I think this is not like coming to a regular meeting. This is your data. And let's see if you can use your data to actually alter your practice. And again, I want to be clear. My challenge to each of you is at the end of today, think about the 3 things that you are going to do differently on Monday based on the lectures that you have heard, and then we can still continue on to measure things. And most importantly, at the end of today, because we are a core health organization, we are going to have a fun Peloton ride. You will be given a different Zoom to join if you want to watch that. Also, we'll share with you the ride that we're all going to jump on. Again, this could be for fun, it could be competitive, it could be whatever you want. But again, that's really to me what the key of this collaborative is. So again, thank you to each of you. And I look forward to a great session today.
Okay, so Carpata, you're banned from the Peloton ride. So just real quick, maybe we could just do a quick example of the, do you have the first question for the poll?
Yeah, we're good. And it should launch now.
Okay, so everybody, this is the way the poll is going to look. If you just take a second, we'll see the results. But the question is, who will win the Super Bowl in 2022? I think obviously there is only one answer to this question. And if you don't know it, you don't know who Baker Mayfield is. Are we able to see the results live for that too? Or you just, there you go. There you go, people. Go Browns. All right. Okay. Well, I'm going to go ahead and introduce the first moderators. It is a great pleasure for me to introduce Todd Harris, who is in private practice, who runs the hernia specialist group in Newport Beach, California, and my partner, David Capata. And they're going to talk about, through their group, a lot of work that they've done, share some data and talk about really some key things about how to optimize data entry. So thanks, guys. Go ahead and take it from here.
Hi, and welcome to part 1 of session 1 of our QI Summit. I'm Todd Harris, a private practice surgeon in Southern California, for those of you who don't know me. I think before I get started, I just wanted to acknowledge the placement of this particular session in the summit. I think Obviously, the research that the QC does is fantastic. The core insights that we've been watching over the last months have showcased all of the research that has been able to be accomplished through the QC. In addition, the opioid prescribing behaviors of physicians has been greatly impacted, again, by the QC. But all that research doesn't happen without data entry. It's sort of where the rubber meets the road, right? We can accumulate a lot of data, and we might not do research on it, but we certainly can't do research on data that we haven't accumulated. So I think as a QC, and as part of the membership committee, which I'm a part of, along with David Kripata and others, we want to ensure that the surgeons are having the most streamlined, the easiest, and the most seamless approach to data entry. And so for the QC to put this session first, and for us to be able to hear from some of the high performers who are entering a lot of data on what they think is working best in their practice, again, I think shows that the QC's dedication to improving data entry for us, because that's really what counts when it comes to growing and utilizing the QC. I think there's going to be some upcoming changes to the QC in terms of data entry, and I think that that's great. Again, I think we shouldn't think of the QC as a static creature. It's a living, breathing organism which can be adapted and can change. And so if you as a surgeon are running into issues in the QC, bring it to our attention. Let us know, because inevitably there's going to be other surgeons who feel the same way. So with that, I wanted to get started. So back last summer and spring, Jeremy and Rebecca sent out a survey to all of us in the QC, and 65 of us responded. And the second question was, what percentage of your cases are you entering into the QC? And by the looks of this chart, it looks great. There's a big green bar here. But when you really look at these other three bars, if we add those together, that's almost 40% of the members are not entering 75% or more of their cases. So that's a significant opportunity for us to improve. When asked what the barriers were to 100% participation, obviously makes it's not a surprise, makes sense that it takes too long to enter cases, and or I don't have assistance with entering cases. So again, the barrier to surgeons participating are time and workflow, some things that hopefully we're going to learn more about this morning. We sent out a survey, a poll to a number of surgeons, a number of you, and asked, tell us how long it takes for you to enter different tabs and different sections within the QC for your patients. And again, not to dwell on the exact numbers, but there's variability here. Within each of these sections, there's surgeons who are taking a minute or 2 minutes or 3 minutes. So again, no matter how good we think we are at this, I think there's definitely opportunity to hear from the high performers on what they're doing. So again, we average that out. And if we look at the average surgeon who responded to us, it takes about 13 and a half minutes for them to enter each of those sections collectively. So that's not an insignificant amount of time. One thing that we asked each of you was not only how long does it take for you to enter, but who's actually entering that data into the QC database. And again, not to go into the details here on this slide, but obviously there's a wide variety, all the way from medical assistants and nurses down to surgeons. And as we get over towards the operative details, certainly more surgeon heavy. But again, there is variability. So we may hear from some of our high performers on, again, what works for them. So hopefully some of what's working for them, we can all add to and implement within our practice. So a couple of maybe non-data entry points as part of the membership committee that I'm on, along with David Kripata. We're looking at each surgeon's involvement with the QC. Obviously, you're investing your time. We appreciate that. But there are times where certain surgeons who have been engaged tend to lose that engagement, have other things going on. So some of you in the QC may have gotten phone calls or emails from us, literally just to learn what your barriers are. We're not calling or emailing you to scold you or to criticize you or to shame you. It's literally more to listen than it is for us to tell. We'd like to hear what your barriers are, what we can do to try to help improve things. And almost more importantly, to let you know, we appreciate the time that you did spend. And if you can get back engaged, then we certainly would appreciate it. So some of you may have gotten those calls, and you may get a call in the future. And again, it's not a criticism. We just want to point things out. So for me, obviously I dropped off in Q2, Q3, but having heard from someone in the QC, that may re-engage me. So again, engagement of the surgeons we already have in the QC is extremely important. And that's why we're here, to learn the tips and tricks on data entry. But again, another small plug for membership as a whole. Not only is it engagement, but it's the membership numbers. And if we look at this chart of the membership growth over the years, you can see we did good until 17, but it's tailed off a little bit. If you break this down into the different practice types, whether it be academic, private practice with an academic affiliation, you can see that we as the QC and we as private practice doctors really have plateaued here and haven't really been bringing new surgeons into the fold. So I think what we would like to do is to create a membership drive. We'd really like to engage all of the surgeons who are currently members and ask them to go out into the community and to try to recruit surgeons in. I mean, word of mouth obviously is one of the best ways for anything to grow. And some of you have probably gotten some of these cards in the mail. We've mailed them to a few of the surgeons that we could. And if you take these cards and you take them with you to a surgery center where you operate, and there's other surgeons there, pick a few that you know that are busy and give these cards and say, hey, this is something I'm involved with. Would you like to be part of this? Take it to the hospital with you. Maybe you ask some of your partners who may not be engaged, but this actual physical card that we mailed to some of you, or everybody will be getting this digitally. So again, if you have a friend from residency that you remember, send this to them, forward that to him or her and say, hey, I'm involved with this particular program. I think we're doing great stuff. And we really want to try to help grow the membership, numbers, especially with us private practice docs. So with that, we're going to hear from our high performers. Really excited to hear from 3 different types. We've got Jeremy, Michael, and Jonathan, academic, and then academic with, or private practice with academic affiliation, and then private practice. And again, we know that all of our practices are different, but I think either, listen to the surgeon that's in your type of practice, or even better, maybe take a few things out of each of theirs and see what you can implement within your practice. So with that, thank you very much. And we'll take the next talk with Jeremy. Thanks.
I think most important. Hey, good afternoon, everybody. This is Jeremy Warren from Greenville, South Carolina. Look forward to talking to you today about some of the strategies to optimize data entry into the QC, some of the ways that we've had some success and where we still struggle in some areas. So I think most importantly, and I think you're going to hear this echoed throughout the talks today, you have to recognize the value added to your practice that the QC provides. Just the ability to have real data, granular data on hernia repair and your outcomes provides you the ability to do true quality improvement within your own practice. It allows you to better consent your patients when you can quote them your SSI information, your recurrence data, your length of stay for a given operation, you can know that it's reliable. This is also a great way to log your cases and helps with maintenance of certification. It's a great tool for research for those who are interested in it, and has certainly provided a lot of high level data, very granular data on hernia repair using some big numbers that are just simply difficult or impossible to get from traditional trials. And I think you'll hear later today as well how this can be a useful tool for you in marketing or maybe even contract negotiation. So again, you have to appreciate the value added to your practice, to you, to your patients, or you're just simply not going to use the QC effectively. So how we do it at Prisma, I just want to walk through with you each of the basic phases of care. So from the new patient visit to the follow-up, and how we use the QC at each of these levels. So first, before the patient ever gets to us, they're actually sent a letter with their new patient package to address the QC, inform them what it is, how we use it, what data is collected, how that data is handled. So they have some background information coming into us from the get-go. And then during the initial visit, talk about the QC. This is not always an explicit conversation, but as I mentioned before, this is incredibly useful for informed consent. So as we're talking to the patient about the risks and benefits of a given procedure or the options of how a hernia could be fixed, we're able to reference our own QC data to have the best conversation we can with that patient, inform them to the best of our ability what their outcome is going to be. And at the same time, assuming that we decide to go ahead with surgery, we have them complete their baseline PRO just in paper form. I'll talk about in a minute about how we actually enter that. Utilizing your EMR, I think, is key. So when you're completing your in-office documentation, having some standardized language in your note templates, I think, is incredibly helpful. For example, I have a brief sentence at the end of my HPI that indicates if the patient takes any opioids chronically or has any psych history. You could do the same thing for functional status, for hemoglobin A1C and diabetic patients. So, use your EMR and use your H&P templates to accurately capture the data that is in the QC. And that'll save you some time on the back end when you go to enter that information. So the actual data entry begins with our scheduler. What we identified in our practice is that the scheduler is really getting a ton of the data that's already in the demographic tab anyway. So she's getting their name, their contact information, their email, their insurance information. So we just had her start to add that demographic tab data into the QC as she's doing the scheduling. And we actually just have her enter that baseline PRO as well, which only takes a few extra, 30 seconds to add that once she's already in the QC anyway. So that's been an incredibly useful way for us to get that initial data entry into the QC. When we get to the point of surgery, this is really where we have to do all the work. The operative details are entered by the surgeon. We typically do the pre-op evaluation as well. The templates used for our H&Ps are incredibly helpful for this. Templated language in the operative notes can be incredibly helpful for this as well. And I think what's most important to entering accurately and efficiently the QC data is to enter it promptly after the case. Ideally, do this while you're doing your other post-operative documentation. You'll remember the time, you'll remember the blood loss, you'll remember the little things that you did in the surgery. Entering this, days or weeks later is just not as accurate and certainly not as efficient. The other thing that's helpful, a new feature, is the save as draft function on the 30-day follow-up. I think this is going to really impact our ability to better capture some of the complications that occur, particularly in hospitalized patients, and particularly if they've been in the hospital for longer than expected. The 30-day follow-up entry is really reliant on the discharge documentation. So if a patient has an ileus or maybe a UTI or something like that that's not explicitly stated in the discharge summary, I think we were probably missing most of those. So having this save as draft function really lets you input some of those complications real time And for me, at least, it's been really helpful in going ahead and putting in the discharge prescribing information for our opioid module. And I can put that in as I'm doing the discharge or as I'm sending those patients home from an outpatient procedure. I think that's an incredibly useful thing for our nurse practitioner on the back end. Our post-op patients are seen almost exclusively by our nurse practitioner. So she's going to enter those 30-day outcomes. Again, the save as draft entries are really helpful for her to make sure we have accurate information, and it helps her just from an efficiency standpoint of having some of that information already entered. And then the 30-day PRO is administered at that 30-day follow-up visit as well. That is currently entered by our research coordinator in the office. We've gone back and forth a few different ways of doing that, and this is seemed to be the most effective and efficient for us. So again, just to kind of sum up and add some times into this, our surgery scheduler is doing the initial data entry in the demographics tab, as well as the baseline PRO entry. The surgeon is entering the pre-op, the common operative, and the operative details. Nurse practitioner is entering the bulk of the 30-day follow-up, aided by any surgeon entered data under the save as draft function. All in all, this tends to take somewhere between 8 and 10 minutes, depending on the complexity of the patient. But on average, we're less than 12 minutes across the board. And we've actually done some analysis of this and had each person time their average entry. And this is about what we've come up with. Some of the areas that I think we still struggle, I mentioned this already, in the 30-day complications, I think we were probably missing a fair amount of in-hospital complications if they were not explicitly documented in the discharge summary. So I think the save as draft function and being able to enter some of those things in real time is a real benefit of this new function. I think long-term follow-up is still something that we struggle with, and I know we're not alone in that. Even the patients that come in to the office for long-term visits, sometimes we just don't get the right time frame and don't get them the PRO questionnaire. So I think we still really struggle with this, and I'm actually looking forward to hearing how other people do this today, and hopefully bring some of that back to Greenville and help us to improve the data entry on our long-term patients. So again, just to summarize here, find a system that works for your practice. This is how we do it, and it works well for us. Not perfectly, but it works well. I know that I've talked with some of you before and have a very different system, and that's okay too. Find what works best in your practice. Enlist your staff to help you out with this. Make sure you're using your technology optimally. So template your HMPs, template your op notes to make those help you in entering the QC data. Enter the data as promptly as possible after the operation so that you don't have a lag, which is going to make you both less efficient in entering the data and potentially less accurate in entering the data. That save as draft function in particular can be very, very useful, especially for the 30-day follow-up. And then just engage your patients. When you can engage the patient up front and particularly engage them on the back end, maybe when you're done with your initial post-operative care, I'll often have this conversation of, hey, you know, we want to know how you're doing in a year from now, 2 years from now, 3 years from now. So this is an incredibly useful way for you guys to give us feedback on how you're doing in the long run, and helps us to take better care of hernia patients in the future. And I think patients really respond well to that. And I do think that's helped us get some additional long-term follow-up. And then look forward to feedback from the group here, from the QC participants on how they do this and how we can potentially improve the process. Some of the ways that I think we're already looking at improving this process is doing some quarterly reporting, which will include some of the data entry components. So how often are you capturing 30-day outcomes, 30-day PROs? How many long-term follow-ups are you getting? What's your overall volume, and are you capturing it well? And I think doing some things to potentially streamline the data entry are being looked at. So maybe rearrange some of the data points to facilitate most efficient entry, you know, in particular, moving the BMI from the common operative page to the preoperative page. You know, that's one thing that you have to look back in your EMR for to get access to on the day of the operation that you otherwise could just enter directly from your your memory as you're walking out of the OR. Maybe even doing some templated operative procedures, that will pre-select certain fields based on the type of operation that you've done. So just things we're looking at in the future. And again, look forward to the discussion today and learning from the rest of the group here how this has been done by your practice, and maybe take some of that back to us here in Greenville. Thank you very much.
All right, so hopefully everybody's enjoying themselves so far. I'm going to introduce the next speaker as well as a couple additional co-moderators. So first off, I'll introduce myself. I'm David Capata from the Cleveland Clinic. I have the opportunity to work with Mike Rosen, unfortunately. So the two other co-moderators we have today for this session are Ragnar Peterson from Ascension Medical Group in Wichita, Kansas, as well as Rana rhymes with Banana Higgins, who's from Medical College of Wisconsin. So I just want to introduce everybody. And in addition, I will also introduce our next speaker, who has made a tremendous contribution to the ACHQC through his efforts in the opioid task force in that group. And that's Mickey Reinhorn, who's coming to us from the Boston Hernia Center. So next up will be Mickey. And then also, please, everybody, put comments in the chat box if you have questions. This way, it will make for a nice, fruitful discussion when we have all the panelists available.
So good afternoon. Thank you for attending this session. My name is Michael Reinhorn. Everyone calls me Mickey. I'm going to talk to you a little bit about data entry in a private practice that has affiliation with two academic centers. One is Tufts University School of Medicine, where we have medical students. The other one is Mass General Hospital, where we have some of our surgical residents. I have no disclosures relevant to this talk. I was overwhelmed when I first started working with the QC about 4 years ago. I felt like this was completely overwhelming, and how is this going to happen? So I started dissecting the problem into smaller and smaller pieces, and I had a medical assistant that was able to enter some of the patient demographics and get things rolling on the initial data entry, but my PA and I would spend a lot of time doing the data entry, mostly my PA, but I would spend hours doing the operative details. It was quite time consuming 4 years ago. I wasn't quite as busy, and so it was doable, but I always thought that there is a better way to do it. So about 2.5 years ago, our practice changed, much more focused on hernia, and I felt like this was an opportunity to delegate a little bit more of the work. And so we hired staff to be medical assistants who are applying to medical school and PA school, smart, motivated, driven people. Explained to them how important the QC was, both for quality improvement, but also for other things like friendship, relationships, peers, and mentorship that I've given and gotten, and felt that it's also helpful for negotiation with insurance companies. And so I really made it clear to my medical assistants. They started doing more and more of the work, and then my PA and I try to share the work, not exactly equally, but we try to share the work. I think that worked pretty well until COVID happened, and COVID both gave us enough time to rethink things and also not enough time to keep up. And so we really made it part of the job. And I feel like this is really the key to our success, is that the medical assistants have completely bought into this. They do 100% of the data entry into the QC. I do a lot of coding. And so what do I mean by that? In the initial visits, the patients are given a pre-op PRO. Our medical assistants enter that on the day of surgery. They enter the demographic, the common operative, on the day of surgery, or even when the surgery is scheduled. So that's all there ready to go. On the day of surgery, our medical assistants are in the office while I'm in the operating room. And so I put in the operative details of how big was the defect, the location of the defect, the type of sutures we used. Did we close fascia? Did we leave fascia open? Did we mobilize nerves, cut the nerves? I have templates for all of these things so that all you have to do is look at my operative note and you know exactly what to put in for that particular operation. So our MAs do that in real time. As soon as the surgery is done, they go in and do it. So by the end of the day, all of our surgical data is in there. They also do the 30-day follow-up note after we put in our progress note in a computer. And then my PA and I typically remind the patients to do the PRO, the 30-day PRO. I think the most important part in the holy grail of hernia surgery is long-term follow-up. And here we devised a system almost a year ago now, where on the first of each month, they're printing out and downloading the list of patients who are eligible for 6 month, 1 year, 2 year, and next year it'll be 3 year in addition. They reach out to them by phone twice until they get a response. They found that that second phone call is a nice nudge to get patients to fill out the survey. I didn't really mention much about 30-day PRO, except that my PA and I remind the patients to do it. Well, COVID was a problem for that. You know, before COVID, all of our patients were coming into the office. They were filling out a 30-day PRO on their post-operative visit. It was going in. We had nearly 100% capture rate. When we started working on this talk, I realized that our 30-day PRO rate was a lot lower. So that reminder that I tell my patients to go ahead and fill out the survey they got by email is just not good enough. And so we've reinstituted now that in addition to the 6 month, 1 year, 2 year, they're also getting the 30-day PRO on a monthly basis from the month before. And so it's a continuous process improvement of how we get data. We make mistakes as our processes change and our patients' flow change. If we don't make the right tweaks about data entry, some things fall through the cracks. And so I think one of the takeaways is that this is really an ongoing process improvement project. But really, I think that the three things that I'd like to emphasize is I think you want to build a system for your practice that really emphasize the importance of the QC and data collection. If everyone believes in it, if you're passionate about it with your patients, with your staff, then they're going to buy into it and they're going to feel dedicated to doing this work. And then I think the most important thing is create a system where you've delegated to the point where you're doing the least amount of work possible so that the data gets done. And so with that, I delegated this work as teamwork. So we created this presentation together. Elizabeth and Wanda, our current medical assistants, are applying both to PA school and medical school. They not only do all the data entry for the QC, they helped work on this talk with me. And so I want to give them credit. While I get to present the talk, they've really done a lot of the work. Lauren, my PA, does pretty much everything in the practice except the critical part of the surgery. And so I felt important to mention her, as well as some of the other medical assistants who for the last 2 years have done a ton of data entry. I think for our 6 months, we have over 240 patients in the last 2 years who have 6 month post-op data, PRO. So I think we're doing a really good job. We could do better. I'd love some feedback and questions if you have them. So thank you.
Great. I think, Mickey, I appreciated your 1.0, 2.0, 3.0, and actually look forward to maybe in the future getting a 4.0. But yeah, I think having or conveying that passion to those in our office is fantastic. I've tried to do the same thing in my private practice and really empower my staff to telling them, hey, this is important. We're really helping and we're really doing great things. And so I think that's something that's benefited me. I actually had one of my MAs, like you had mentioned, Mickey, the COVID situation and patients aren't coming in. And I didn't really think about that either. And one of my MAs said, oh, Dr. Harris, because the patients aren't coming in for their 30-day follow-up, I've started to call them on the phone and check the boxes for them. And I was completely blown away. I had never thought about it. And I was super impressed with my office staff that they were doing that. So I think that, again, if we convey passion to those in our office, it's great. And then to delegate, looking in the comments with the chat, and Bruce Friedman had said it's very time consuming. And he's right. He's got an MA who's already overwhelmed. And so it's not easy. And we'll talk about it in the discussion portion, but I do think delegation and because as much as your MA is busy, you're probably even busier than your MA. So it's really hard. I agree with Mickey. The less you can do, probably the better off. So with that, I'll introduce Jonathan Eunice, who's at the Center for Hernia Repair in Sarasota, and we'll see what he has to say for private practice physicians.
Sarasota, and I've been asked to discuss strategies for optimizing data entry into the ACHQC as a private practitioner. I think the most important issue in entering the data is to really appreciate the potential benefits. Just imagine if all of your variables of your previous surgeries had been entered perfectly over the last 5 years, as well as your outcomes. The value to the surgical community as well as to your own outcomes would be amazing. Obviously, that's quite. The other thing in private practice, I am working toward a relation with academic colleagues, as I am in many ways alone as a hernia specialist. I'm very close to my surgical colleagues. But by being in the ACHQC database, we certainly are overlapping. Also, I think I have an obligation to contribute data as a single surgeon. This is quite valuable going forward. Also, we often get from patients the question of, hey, doctor, what's your recurrence rate? And this is often difficult to answer if you don't have the exact data, and it would be nice to be completely transparent with accurate data. Also, the choice of operation is a big frustration in my practice. I know even though I have become facile with open, laparoscopic, and robotic procedures, it is often very difficult to know what is the best possible way to recommend for a particular patient. The other value is to kind of see where you are on the curve. I'm always pushing myself to get better. And I'm also very active and do quite a bit of surgery, as you can see here. Other tips and tricks. Obviously, the front office staff enters the demographics at the time of the booking. And you would also want to enter your data as soon as possible after the surgery, and to actively memorize the workflow of the data entry. What I mean by that is I noticed after a while that I was looking backward and forward, but the more I concentrated on memorizing exactly the sequence of questions in the database, the easier and more accurate was my data. And most importantly, you got to get one of these, a really smart, motivated physician assistant, and do everything you can to motivate them and optimize them, pay them well, engage them in the office, teach them everything you know. But it is important for me to frequently review the accuracy of the data that she's entering. I have to keep her on task. We discuss it a lot. And you got to remember, you know, if the data is not put in accurately, that old saying of garbage in only reveals garbage out. So we really want to make it very accurate. So what about entering data for follow-up? Well, it's pretty obvious that you want to organize your office follow-up to correspond to the QC follow-up. 1 month, 3 months, 1 year. And also you want to enter that follow-up data when they're in the office and as soon as possible, so you don't forget to do it and the accuracy is proper. So the greatest weakness in my practice is the follow-up data, as well, I'm sure, as many of your practices. And one of the interesting things about follow-up data in the office is that we tend to record only problems because they stand out. We have some selection bias onto who gets recorded. When I see a recurrence or other complication, we tend to enter the data, but for long-term happy patients and a busy office, we often neglect to enter these happy patients as the denominator. The ACHQC database, everyone knows, you can be looking exactly where you're at a moment in time. I do believe that composite hernia recurrence and patient outcome, described recurrence, patient reported outcome is clearly something that is likely to be lower than the data I'm recording, because again, I am recording every complication and certainly have been very lax at recording long-term results with patients that are happy and have had no recurrences. Similarly, with the patient-reported European Hernia Society composite, I think that myself, as well as my patient's response to the emails to complete in the long term about the quality of their surgical results, has been far from perfect, and I'm motivated to improve. For those people that really are entering data, it is very important to realize that the European Hernia Society in 2012 met and published the guidelines for data follow-up of ventral hernias in the journal Hernia. The European Hernia Society quality of life score is a method to measure the quality of life for patients before and after the surgery. And they specifically wanted to look at pain at the site of the hernia repair, restriction of activities, and cosmetic discomfort. That cosmetic discomfort likely it needs to be translated in a different way due to some confusion, at least among my patients. And that you recognize this is the data from the original paper in 2012. And it's very important that we all stay consistent with these questions so we can be comparing notes. But at the same time, I think it needs to be rewritten somewhat because I think there's some confusion in my patients about, if they don't bike ride or they don't play sports, it's just a little vague that they have to check that X outside the box. So my patients find this particularly confusing, and I've discussed this with several people where it's asked, what about the shape of your abdomen and just this concept of cosmetic discomfort, maybe that can be changed to cosmetic satisfaction. But in terms of the shape of the abdomen, one of the big issues that we find is that the patient often has extraordinary amount of visceral fat and or a pannus, and that even though the surgical repair area looks excellent, the shape of their abdomen to the patient might still be cosmetically ugly, but I'm not sure how that reflects on a well-performed cosmetic repair of the hernia itself. In the second line, where we're looking at the side of the hernia and the scar, that is much more specific about the cosmetic appearance of that. However, certainly we see confusion in that a lot of the patients don't even remember which side their hernia was on or where the actual hernia was. So I'd be looking for several things in the future. And what I'm hoping for is a phone application, which is optimized page by page. And I think this is important, even though I know it's expensive and we may be far off from it, because myself and maybe many of you were restricted in access of the internet or off-site sites in many locations in the hospital, and it's just easier if we could do it on your phone. And similarly, it's not easy for me to run around the hospital carrying a laptop. The other thing I'm hoping for is an enhancement of the Inguinal database. Specifically, I want to be looking at the different techniques, and just as we do in ventral hernias, where we have robotic, laparoscopic, retromuscular, et cetera, that if we can really have that filter on the inguinal side, we can have a much more easy query of the data that you can do yourself, as opposed to asking help from others. And similarly, I think it's important to have a unique database for umbilical hernias and epigastric hernias, because we still find the management of these quite controversial. And it is a little difficult that they're mixed in with the ventral hernias because they're completely different. And also they don't have to be quite as extensive of questioning for small umbilical hernias. Another idea that I'd suggest is that we encourage surgeons who are entering data to use a caliper in the operating room to accurately define the size of the hernias, especially small umbilical and epigastric hernias. After you start looking at what size they are, most primary umbilical hernias are 1.5 to maybe 2 centimeters in diameter. And if we're really looking to match up the diameter size with the optimal outcome based on the optimal operation, a few millimeters might make a difference, and it'd be better that we're not estimating, which many of us likely are. The other confusion that I see is in sporting activities, the frequency and severity. I think this is very important. When I see athletes, I feel significant more pressure. I'm sure as many of you as well feel this, because these people are in touch with their body, they feel things, and they need to perform. So I think it should be entered on everybody with every hernia, but it should be 2 separate things. The frequency of the exercise, are you doing it once a week, twice a week, every day, twice a day? And then the second piece of data would be the severity, meaning are you a world-class triathlete, a weightlifting competition, or you just ride a mile around your community development for 1 or 2 times. So ultimately, I'm recommending that we enjoy every moment of the surgery and to accept the small inconvenience of the data entry. And to remember, it's a privilege to be a surgeon. And the effort of data entry for outcome enhancement, I think, is an obligation. Thank you.
Thank you, Jonathan. I would echo that last comment that you made there, and thanks for some of the great tips, but also some of the great suggestions. I think it's important that part of this is that we continue to evolve the ACHQC, and I think we're always looking for that feedback to see where we can improve, and I think that's some great suggestions. So continue everybody offering up suggestions for improvement. And with that, I will introduce our next speaker. It's a pleasure to introduce Will Hope, who's from New Hanover Regional Medical Center in Wilmington, North Carolina.
I appreciate the opportunity to speak at the QI Summit for the ACHQC, and I appreciate the invitation. This is a talk on insight from our members and really is about institutional and academic value. I'm William Hope. I'm a surgeon in Wilmington, North Carolina. So we're going to start by really kind of giving a brief overview of sort of what I think some of the values are of this platform, of the QC. This really is about academic value, but I think that it goes well beyond that and really is about I think every surgeon can really take this no matter what kind of practice you're in. So here's our outline. I'm going to spend a little bit of time on this because I think we're going to hit a lot of these sort of superficially, and hopefully you're aware of all these things that I'm going to be talking about, but there's a lot of great stuff that the QC is doing, and I want to hit the highlights. So obviously, the leadership of the QC wants to make sure there's value in the QC, and I think value may be a little bit different for every surgeon, again, based on sort of how they practice, but there's no doubt there's a lot of value out there depending on how you use this, but there's a lot of ways to do it. And I'm going to show you why I think data is important. I think we all probably feel that way. There's a lot of opportunity for quality improvement using the QC database, and I think a lot of those folks in our hospitals is really, I'm a residency program director, so quality improvement is something that the residents really need to be involved with, and I think hospitals are really engaged in this as well. You can use this for some hospital committees that you're on, obviously the quality committee, but one of the interesting things is maybe looking at this to use in a value-added analysis committee about mesh, and I think we'll hit that as well. And I'm going to go over some examples of how the QC can change and support practices, both academic and institutional practices, as well as community practices. And then, of course, academic surgeons like to publish, so we'll go over a little bit about some of the publications. I think data is king. We've heard this for a long time as surgeons. I think we all are aware of this, that it's really important to know your data. And this is really, to me, the QC is one of the easiest and best ways to get a good, solid data for you, and it allows you to compare yourself to your peers. And sometimes that's not always fun, especially when you're not quite as good as your peers. And I'll show you some of my data related to that. But I think it's a way for us to get better. And this is, in most cases, a non-punitive thing, and it's just a way for us to learn from each other. One of the other great things about the QC is a lot of the hospitals that we work in, the data that they're using is really administrative data, which can be good in some ways and for some of the things they're doing. But for hernia, I think we always question, the accuracy of some of these big databases is really, whether they're good for us. And I think the QC metrics that we put in are really the ones that we want. And I think this is where you can get buy-in from your hospital, especially if you don't have a quality initiative around hernia, or if they're looking for something that, it's really great if you could get the QC to sort of be the quality outcome metric for your hospital, and then that'll allow other surgeons to get involved. This is an example of quality improvement from me. This was early on in the QC, and what I found was I was an outlier for 30-day readmission. And I think clearly the QC is great at looking at 30-day outcomes. Readmission, every hospital that I know of is really interested in readmissions. So that's partly how they get paid. So I was an outlier for 30-day readmissions, and after I kind of realized that that's probably true, and that this was data I was putting in, so it is, and that other people were better at this than I was. And I really kind of figured out that there were probably some readmissions that I was having that probably was low-hanging fruit that I can improve upon. And this is where Ben Palouse really helped at the beginning of this and did a great QI project, really looking at can we decrease 30 days to readmissions, and in a fairly simple way. And this was a survey that you could have your nurse, and my nurse still does this. She likes doing this. Call our patients after surgery. We found that really a lot of the readmissions were related to surgical site infections or bowel issues, and so there's some questions related to that. And if they answer yes to those, then what I used to do, or what my nurses used to do, was tell the patients just to go to the ER. And if I wasn't on call, the resident would see them and then just admit them, and I'd see them the next day, and there was a readmission that we really didn't have to have. And so I think there's some ways to improve. Hospital loves this, even if you don't hit the target of something that you're trying to do. If you just show that you're working on some quality improvement initiatives using the QC, I think that's a major win. And like I said, residents and fellows need to do this. They need to learn how to do this. And so I think it's a great way to do it and an easy way to get some data. Hospital committees, besides the sort of quality committee, which we talked about earlier, I think one of the interesting things, we have not used this for this, but I think this is as I was putting this talk together, a potential great way to use this. As we all know, when we put in our mesh, what kind of mesh we use, and for the majority of this, I tend to use a lot of permanent synthetic, but I suspect if you looked at the surgeons in my hospital, you would probably get some very different graphs as they tend to use some different products and different types of meshes. And so if I was a hospital and interested in sort of decreasing our clinical variation, especially, if it was appropriate, And I think the QC could really be a good way to use this and look at our mesh use and make sure that we were doing all that appropriately, especially if we were bringing in new products. I think the QC has really gone a long way to change practice, and I think that's clearly one of the reasons this was started is to try to answer some of the burning questions that we have for hernia repair. That several of them still remain unanswered, but we've taken a good shot, and a lot of good investigators have really been thoughtful about looking at some of these things. But also supporting practice. And I can't go over all the different research projects, but of course you've seen some of these at the QI Summit, whether it be tap blocks or epidurals, or, do we need to put fixation in mesh, or, coated mesh, and all the different types of techniques. And I think they've done a great job at really answering some of these questions. And clearly, we've changed some practices because of that. But I also think the QC surgeons really support practice. And anytime I can put a picture of Mike in these silly hats, I try to. But this was interesting a few years ago, where there was a big stink about the AORN, guidelines about Buffon and surgical caps. And, the QC was very nimble and very quickly could get some data about surgical caps. And this was, again, a great way to use this. And we got some data, really one of the first papers out to sort of support the use of surgical caps, or really you could wear the cap that you wanted. And so very supportive to surgeons, whether you're an academic or community practice. The QC helped with that. Other things that the QC does, I don't know if everybody uses this, but it's a great tool, the brief op note. Most of us at the end of the case put in a lot of this stuff in the QC at the bedside computer. So this just decreases the step of doing your brief op note. Every hospital requires you to do a brief op note. It generates this for you, and you can just, copy and paste this into your electronic medical record. One of the great things about this is it allows for, it really gives you all the information that you would want in a brief op note, which we don't always put in if we're just typing this at the end of the case. And so if you were to look back at your electronic medical record, most of the good data would be in there. And then really another up and coming thing that I hope hopefully everybody is familiar with or is starting to use is the Oracle. And I really think we've used this in a few different ways. Clearly the Oracle part, where you can sort of sit with a patient and go over some outcomes and risk factors and sort of give them an honest, based on the QC data, an honest interpretation of what their outcomes may be, I think is really important, and patients really do like that. But really where we've used this the most is really the prehab and rehab and sort of the exercises that patients can and can't do. And when I talk to my nurses, really the number one phone call we get amongst our practice about hernia patients is really what they can and can't do after surgery, despite us really talking to them before surgery and right after surgery, of giving them some clear guidelines. They still don't get it, and one of the nice things that our nurses do is they just refer them to the QC and the Oracle app. They pull it up, they see some of the exercises they can do. I think they feel engaged with that. So we really enjoyed doing that, and I think our nurses really like that. So publications, obviously academic surgeons like to publish papers. They like to look at data. In some institutions, that's really important for advancement in careers. And so this is a great, easy way to submit a publication, submit a question to the QC. It does go through a process of where it make sure that it's a valid question, it's something that hasn't been done. But almost all of these get approved, and then you get to work with a statistician, a data person to give you some data. And you can see these aren't all the publications, but these are some from our group. That whether it be a resident or a fellow that has done some of these, or a lot of these have been in collaboration with other surgeons. I think that's a great way, kind of get a group together and query the QC and get a publication out there. And clearly the number of publications and the impactful publications that come out of the QC is really great. But almost everybody can take part in this and really publish a paper, whether it be on your own data or using the entire QC. So in conclusion, of course, I think the QC is very important for academic surgeons and institutions, as well as community surgeons. And we see that from all angles. But even community surgeons can have some academic endeavors by using the QC. It clearly fulfills a lot of the goals of an academic surgeon of publishing, quality improvement. There's some grants that your residents or fellows can apply to. And while they're competitive grants, the number of grants that are submitted to this aren't as big as some of the other grants that you may be applying for. So there's a good chance that you could get this. Clearly, peer review publications is a great way to do that. It's a great way to get started with the QC and see how you can get some of these published. Of course, one of my favorite parts of the QC is really the collaboration that we have. And unfortunately, we can't all be together because I think the Quality Summit has really been one of my favorite meetings over the past few years. And I think it's great to see like-minded folks and get together and meet a lot of people. So unfortunately, we don't have that this year, but hopefully next year. But one of the other great things that hopefully you're aware of, and if you haven't, I would really recommend it to you, is the QC Core Insights. They've had a few of these already. They've been spectacular. It allows for surgeons to talk about their research. It allows for some surgeons to be panelists on this and sort of, kind of debate some of this and really get to the bottom of some of these really complex and controversial questions. So the Core Insights is a great way to get young faculty members or people on, talk about these hernia situations and complex stuff. So I recommend all of these to you. I think, again, it's a great way for us to all, be a little academic and support our institutions through this process. So thank you very much.
That's great. I appreciate it, William, and sharing with us the value that you find. And it'll be interesting to see, comparing the academic center that you're in versus private practice. We're going to be leaning on Jonathan a lot today as our private practice expert. So we'll see what he says about value in his practice. I think the question that I really have in my mind with Jonathan's 3 talks is he going to do a wardrobe change between each one, kind of like Judge Judy, or is he going to go with that nice blue polo for all 3? So let's find out.
The second topic that I've been asked to present is about describing the value of the ACHQC to private practice. I think this is a very difficult topic. I'm not, sure how the two blend in, but I certainly am in my own private solo practice, and I'm very dedicated to the Quality Collaborative, and will try as best I can to give you some feedback about what I think of this. So in private practice, the solo private practice barriers are numerous. And as a solo practitioner, I'm a bit of a dinosaur. I've evolved this way. I've been mostly in multi-specialty groups to single specialty groups. And ultimately, as my hernia practice evolved, it became most appropriate to be a solo practitioner. So I am a bit of a dinosaur, but I'm a new dinosaur. And I predict my dinosaur species will be increasing as time goes on, because in the end, I think it is the best way to make patients happy. But there are several barriers. Number one, obviously the overhead. You're by yourself, and my overhead is huge. I have a physician assistant, an RN, and 3 clerical people. The billing software, malpractice, rent, it just goes on and on. So that's one issue. The second issue is the general poor insurance reimbursement, which is everyone is familiar with in our specialty. And then the third aspect as a barrier is that most places are consistent with where I am, where most of the physicians are owned by the hospital or a big multi-specialty group. So rarely are there any solo practitioners or small private practices. I'm the only, general surgeon in my area who is not either employed by the big hospital group or by a multi-specialty group. So the barrier to that is that everybody used to send me hernia cases, and now they only send me their family or complications, and most of my practice is based on word of mouth. So the value of a private solo practice is numerous. The independence is awesome, although I always love being even in a multi-specialty group, and I love being in my single surgical specialty group. You could collaborate and discuss cases. But I can still do this, and on the business end of it, the independence is unbelievably great. The other thing is that people use this word patient-centric, which is really common these days, and there is no better place to create a patient-centric atmosphere than in a solo private practice, because I'm able to influence people and pick people that will echo what the patients need, which is to be listened to and to be taken care of at a personal level. Another amazing thing about this, my private solo practice, is it's so quiet and peaceful in my office. You know, growing up in surgery, you know, between being up all night, emergency rooms, and also in the office, there was always a lot of commotion with other surgeons and lots of patients and people angry and upset, and vascular lab machines blasting and, you know, right next to me. So the quiet and peacefulness in doing one patient at a time, patients are loving it. So what are the solo private practice success strategies? Well, I think one of the most important things that I've done, which has gotten to me where I am and maintains a big part of my volume, is I have such a positive relationship with all the other general surgeons. Basically, there really is no competition. You know, we all are working hard to be good surgeons and take care of patients, and everybody has their own interests. And there is so much work that by maintaining good relationships with other surgeons, I'm there, I teach them things, they teach me things, I send them gallbladders and colon resections, and they send me multiple recurrent ventral hernias. So, other strategies with marketing, not so much. You know, nobody's really looking for a hernia surgeon through an ad in the newspaper. So, you know, I don't do very much marketing. We just do everything we can to maintain quality, which is a big part of getting back to the ACHQC, is, you know, transparency and quality. Also, my strategy is this creating this office culture where everybody's on board. People believe in our practice, meaning, you know, the staff, and how we do things differently than the hospital. The other important strategy is that I need to have a very high volume in order to pay for that significant overhead and to combat the low reimbursement that is in front of me. But at the same time, I need to be dealing with this high volume in a pleasant and productive way, especially because I want to do this for many more years. So I'm always working to improve my outcomes and my stress level, and by looking at quality measures and entering data and evaluating my data and seeing what works best, my volume increases, my quality of life increases, and other things that are helping is the abundance of education that I pursue and observation of other surgeons. So I am the eternal student. That pretty much is the formula to success. I see many who have kind of learned the way they do it, and they do it the same way all the time. I'm always looking for new options, and clearly the academic world tends to be the creativity of growth in the field of hernia surgery, and I am following that closely. The ACHQC enhances my involvement with the academic world. I am very lucky that all I do is hernia surgery as a private practitioner, so it's a little bit easier to keep up with the ongoing literature than it is for general or vascular surgery. So how did I get here? Well, my father was a prominent nephrologist in the New York metropolitan area. And he had a very good friend, Stanley Berliner, who was one of the original hernia surgeons in the American Hernia Society. Because remember, this field that we're all in now really wasn't like this 20 years ago. When I was a resident in surgery, which was actually on Long Island at State University of New York at Stony Brook, Stanley Berliner had a private practice near my father, and I developed a relationship with him, watching him operate. He used to do beautiful shoulder ice repairs basically all day. So we had a very, you know, kind of gentleman's practice, and even offered me early relationship, or at least employment in his practice. But ultimately, even though I thought it was really interesting, I couldn't imagine just becoming a hernia surgeon. So I had to, do much more and become a vascular surgeon. The other thing that influenced me early was a gentleman named Maximo Dezine. He was a very unusual, wonderful bit of a character who was very early in the movement toward hernia specialization. And he taught me a lot also in my early career about hernias and the importance of certain techniques. Ultimately, I got very interested in vascular surgery, and I did a vascular fellowship. And during my vascular fellowship, there's one thing that really struck me, which is all of a sudden I realized I don't have to be the one doing the surgery. So being a good observer of others is what I learned when I was in my fellowship. Like, you know what, I took a step back and watched the professor do the surgery because my hands can move as well as his. I could see what he's seeing, but the watching other people operate really became very important in my career. And then ultimately my vascular surgery practice, which at one point I was a full-time vascular surgeon, merged with a general and vascular group. And then hernias started to come in front of me, and I had a renewed interest, and then this history. I still, however, to this day, maintain my vascular boards, and it's amazing that I'm still board certified in vascular surgery just by taking the academic tests, and I haven't done a vascular case in probably 12 years. So the other way that the ACHQC is involved in benefiting private practice is the government mandate quality measure, specifically the merit-based incentive payment system, which as a solo practitioner, I'm going to have to pay attention to because no one's going to do it for me. The merit-based incentive payment system, otherwise known as MIPS, is something where participating in the ACHQC qualifies me and makes this very easy, because otherwise I don't make the effort, despite the fact that the severity, not just, it's a very small amount of money that you can make extra by participating, but look at this penalty they're proposing, 9% if you don't participate, so, and it's often quite irrelevant, some of these quality measures, but at least the QC is helping me meet these requirements. And marketing with the ACHQC, not so much, but measuring my practice's quality through the QC does increase patient satisfaction and word of mouth referrals. Payment or reimbursement, not so much. No insurance company is really paying attention to the quality that's relevant to my practice or most practices. And their payment is based on how little the surgeon will tolerate. So I'm always working on ways to get better so that my practice can emerge beyond the current system of reimbursement. In terms of the benefits of long-term follow-up from the QC, you're understanding your patient satisfaction, your recurrence rate, and the QC allows for ongoing improvement and, again, happy patient referrals. So the QC also, as I discussed earlier, influences my choice of operation and what is best. From good data entry into the QC, I can have a more straightforward decision tree about what is the best operation for a given patient, and that decision can be made faster. So the conversation in my office can be shorter and more effective when I know for sure what is best for somebody. Also, when I speak to patients with this level of confidence, their confidence is higher, and it all makes for a good thing. So when we look at what we currently use typically for data decision making, it's old data. The question that I ask myself is, the described outcomes from 5 to 20 years ago really apply to what I'm doing today, especially with robotic technology and better lighting and better equipment and better education. And also, didn't the improvement in operating room lighting technology, that led to improved pelvic surgery outcomes. We're seeing things like this too. So old data, doesn't really apply because we're seeing things so perfectly. Also, didn't laparoscopic surgery improve wound complication outcomes? And that also is something that is not well defined in data before laparoscopic surgery. And here's one that's particularly interesting is, many of us, robotic surgery is absolutely amazing. And doesn't the Da Vinci ultra high definition 3D optics improve our handling of anatomical structures that otherwise could be associated with pain when they're not as well appreciated? So the other issue is patients ask, as we discussed before, what my recurrence rate is, what my level of experience is. I could show these things to them. This is how the QC could help. And then the value is also in my transparency, my link to the academic world, and tools for prediction of the best choice of operation. So the 4 A's for success in private solo practice: availability, affability, ability, and the ACHQC. Thank you very much.
That was really fantastic. Perfect way to end that. So we're going to start the panel discussion. Just a couple points. Number one, we're going to try and use the Q&A because everybody can see that. We're having some issues with everybody being able to see everything in the chat. So if you have questions now, please put them in the Q&A and we'll go through those. The other thing is I just want to let Mike Rosen know now that I'm starting private practice on Monday. That's what I've learned so far from this. So you can take all my
You guys can have him. You guys, he's high maintenance. I'm just warning you right now, Jonathan. You better bring 50 people with him.
Boston needs somebody to do the chronic pain patients, Dave. So we welcome you here.
All right, I got options. This is great. All right, so we have one question so far in the Q&A here. I'm going to go ahead and read it, and then we'll go to the panel and see. So I'm unaware of how to access the data. Example, how do I know the recurrence rate for robotic incisional hernia repairs for all participants? Should I submit this as a question for the QC? Just an example. So does anybody want to, how about Rana, do you want to go ahead and address this question about accessing data?
That is a big initiative that's being taken by the QC, is to allow more transparency of the data. There are, I believe it was Dr. Hope had mentioned these previous studies that have been published. There are studies out there about robotics, specifically robotic incisional hernia repairs. There's a study on robotic IPOM repair and a study on robotic retrorectus repair using the ACHQC data. That really captures the national data. But Mustafa, in regard to your question about answering a specific parameter, I think that's being worked on quite significantly with these quarterly reports, and I think will give surgeons a lot better guidance as to their recurrence relative to others as well.
All right, and another question in here. This is actually for Jonathan to answer, and I'm going to tag on to this question too if I can. So it says, besides your best operation, how about your in-depth discussion with patients, a reference type of mesh you opt for? And just to tag on to that, because I'm curious in terms of the way we try and get long-term data. I think we heard a lot about how people set up their structure for getting the data into it, but what do you tell people at maybe their 30-day about what's going to happen in a year from now? Do you follow everybody up at a year? Do you tell them they're getting a phone call? How do you address that to try and make sure that they're prepared for the ACHQC to reach out, or somebody from the office to reach out in the years to come?
Well, first of all, I want to just tell you that I didn't get the email that the real meeting was canceled. I don't know if you can see the mountains behind me. But anyway, the way I deal with the follow-up obviously has been poor, as I mentioned. In fact, this meeting itself has something about, looking at what I'm doing and the potential value of it is that I've been talking to more of my patients about the emails, and I'm in a community where you know, a lot of senior citizens would love to be engaged with an email related to their surgery. They love talking about that stuff. And I don't know, there's just somehow there's this misconnect that they're not, you know, responding. So we're going to have to get much more aggressive in our office with follow-up phone calls in 3 months and 1 year. You know, I am definitely seeing much, you know, the complicated recurrent ventral cases in my office in those times. It's just hard to see routine inguinal hernias. So those patients will probably be done via phone calls.
Mickey, you want to tag on to that? Anything that you do in your office in terms of really trying to set people up for that long-term phone call or anything like that?
So, you know, as part of the informed consent discussion, once I've done all of that, I talk to them about the QC and I give them their preoperative survey myself. And I tell them this is really important. This is how I was able to get you exact numbers about our complications, readmissions, and that way. And I tell them, I said, you participating in this is going to help your care as well as future patients. And then I tell them, I said, you're going to get this exact same form at 2 weeks, 6 months, and once a year after surgery. We hope you fill it out. If you don't, my office staff has been trained to call you and make sure that you participate in that, because that's part of being in our practice. So that's how we do it.
Yeah, could I just add one quick thing to that, David? I think there is such a theme from everybody's talk, which I think was really impactful for me to hear, because I often talk to people who really struggle starting with the QC. And I guess I try and say the same thing, but not quite as clearly as all of you guys have kind of put it on these talks, is that this is a process. And it's a major process change for most of us. You know, we kind of take our ownership of our quality and our outcomes that honestly, nobody's ever really held us to task to do that. So what I like to say, and I mean, I think Mickey, you put it best, is that, you know, you can start with the QC without outwardly trying to solve the most impossible problem of long-term follow-up. There's a way to start with the goal of, well, let me just get, you know, what happened in the operating room and perhaps 30-day follow-up where we all have a contact with the patient. And truthfully, that's what I did in my practice. And then let me add on, well, after I do that for a couple of months and I figured this out and I've worked out my system, let me add on getting the baseline PROs. And then let me figure out if I can do PROs this way. And then maybe I'll do that. But I really think the theme that you guys all put so nicely is that, you know, even if we all get what actually happened in the operating room and at 30 days, that's a big deal to see what's happening. And then I think that the process of accepting this is important. So I'm just curious kind of what the panelists think, because a lot of times surgeons are very type A personality. And I think this is the biggest barrier that they put up is, I mean, I can't figure out what's happening in 2 years, so I'm not even going to start. And I think a lot of people miss just based on that. So I'm just curious what you guys think.
Yeah, I mean, I'll say from my point of view, when I first started, I handed it all off to my staff and just thought I'll kind of supervise. And I think over the last couple of years, I've taken some of that back and you know, maybe done more of the operative details. But I agree. I don't think any surgeon who's just starting, it is hard to find the time, have your office staff find the time or you find the time, but just take that first step. We also, if you want to do it perfectly to start, you'll never do anything, right? So just take that first step and yeah, I mean, start the process and then see what naturally evolves for you. And you know, whether your office takes over, it's a hybrid approach, they take some, you take some. I think that's, you know, sort of what's worked best for me in the last, you know, year or two.
Mike, I'll add, you know, I think, Jonathan, my experience with insurance companies is initially they didn't really care about quality. but I approached some and said, you know, I'm not really interested in participating in your network. You're not reimbursing us enough. And I showed them, I said, we report all of our data. My practice is mostly hernia. And I showed them my QC data. And a couple of them doubled my reimbursement. Now it went from 80% of Medicare to 150% of Medicare, but one is paying me 250% of Medicare to do surgery in an ASC. And that's a national company. So offline, I can share that information with people, but you know, it's a possibility, and I think we're headed that way. I think the pendulum is going to swing toward value-based reimbursement and care. So I agree with you there.
In terms of starting with the QC, I was very I was a control freak, and I did it all myself for several years, and had a bad experience trying to. My first rollout to having the office staff kind of participate in it was very difficult, and we actually, you know, had some substandard data entry for 2020, and so now I've taken that back, but it's actually been a process of learning where we really refined the process with limited resources, and the failure has actually encouraged to a significant degree refining our process. So I think it's really important, number one, that I started out doing a lot of it myself, realizing that it had to be a group effort in the office, and then failing with that effort the first time and really figuring out how to get good data flow through the office.
All right, there's another question in the Q&A. I think this one's either going to be for Ben or Mike. It's more about definitions in terms of how the ACHQC defines private practice.
So there's a couple different ways, but the reality is when you sign up, we ask you how you affiliate yourself. So the truth is it's a self represented term. I think from a little bit more of a complicated answer, the way that the contracts are signed, that distinction is a little bit more important, because if you are in truly private practice, which essentially means that you control your own PHI, you have your own office, you can still work in a hospital, but you control that. We can sign the contract with you directly. If you are affiliated with a hospital that you are often paid, it can be a little bit more complicated than that, because if you're just taking call and getting paid, you can still be in private practice. But you know, if who the contract has to be signed from is probably, for me, the biggest difference, just because if you're able to sign it by yourself, it's actually quite straightforward for us. If it has to go through the legal contract office, it can be a little bit more complicated. But mostly it's how people define it themselves. And I mean, I think as you saw today, you know, the lines are very blurred in this. I don't know, Ben, would you agree with that definition?
Yeah, I do. And a lot of the designation is just self-determined in terms of, you know, what your practice is. But as the questioner is kind of hinting at, yeah, there's kind of a spectrum of private practice to private affiliated. So we really allow just kind of self-designation of that.
Interestingly, I would just add one other thing. I don't think anybody mentioned it in their talks. I mean, one of the things that our group does, at least I do, I don't actually know what everybody else does, but I have an incredible secretary who is just unbelievable, but she gets the surgeon incentive at the end of the year, and you know, she's super appreciative, and it makes a big difference. So you know, I think for her it's a very tangible thing, especially when it's a couple people. It could be a substantial amount of money. So she is very engaged. I mean, she would be engaged anyways, because I happen to have an incredible assistant, but it certainly makes it nice, and that's just another opportunity, depending on, you know, what that incentive is and how engaged that they are.
Mike, just to follow up the question about private practice with academic affiliation, just to answer it a little bit more kind of definitively. So if you're in private practice and you don't have an affiliation or a clinic appointment with a medical school, then usually you're just private practice. If you have some affiliation with a medical school, or honestly, even a PA school or an NP school, and have an academic appointment, those are the typical ones that are labeled, typical practices that are labeled private practice with academic affiliation.
All right, I think we've addressed the questions in the Q&A. I think we had a good first session. I want to thank all the presenters for getting their videos in, and thank everybody for their chat participation and their Q&As. And then we'll take a short break, and then we'll get started around 1:45. Is that you want to stick
Yeah,
with?
let's try and jump back on at 1:45, just so we can kind of stay on time, because we've got some great sessions coming up. I know there's a virtual marathon, but I appreciate everybody's attention. Thanks. Great job, moderators, panelists. Thank you so much. We'll just take a quick break, and we'll be back 1:45 sharp. Oh, and thank you to Aileen and Nicole, who are running this AV, who've taken a class and have done spectacularly. Great job.
Thank you.
started.
Hey.
Okay, guys, go ahead, Ben.
Yeah, let's do it. Welcome back, everyone. It was a great first session, and I hope you got some wonderful tips from our top performers on data entry. And I think we had also a really, really useful chat. I'd ask everyone to go ahead and try and place your questions in the Q&A. That way, all our participants can see it. If you do want to use the chat, try and respond to all attendees, again, so everyone kind of can benefit from the discussion. I'd like to kick off this session. This is going to center around inguinal hernia. We're going to kind of get into some nitty gritty about some technical details and tips about how to do our procedures to the best as we can from experts across the country. I'm going to introduce our moderator for this session, Ron Lewis. I've known Ron for several years now, and Ron has been a big supporter and a participant in the QC. Ron is in private practice in the Northeast Georgia Physicians Group in Gainesville, Georgia. And he's got a wealth of experience in abdominal core health and specifically in an array of approaches to taking care of hernia disease. So Ron, great to have you.
Yeah, I appreciate the opportunity today and welcome everybody to the inguinal hernia section. Fortunately, I've been tasked with introducing 3 surgeons who actually need no introduction. So without further ado, Dr. Jonathan Eunice again from Sarasota, Florida, the Center for Hernia Repair, with a talk on single surgeon experience with Schuldeis, Desarda, etc. Dr. Eunice.
Hi again, greetings from Sarasota, Dr. Eunice here. I was asked to discuss my experience with these techniques for management of inguinal hernia. These are my primary choices for inguinal hernia repair. Clearly, I am doing much less open mesh repairs and much more robotic repairs and open non-mesh repairs. The choices that I'm making are influenced not just by patient demand, by multiple factors, which is what we'll discuss in this talk, but clearly I am also significantly influenced by my frequent encounters with a large portion of my practice being a post-herniorrhaphy inguinodynia practice from other previous repairs, which are usually open mesh repairs of different types, as you all know. The choices that we have would benefit from some simple algorithm. In order to determine the best option for each patient, I would love to create some simple algorithm. I'm always looking for this in any talk that I see among certain experts in hernia repair. I don't think this task is very simple because of the numerous pieces of data that we use to make these decisions, and it would be much simpler as a surgeon if the decision tree was that simple. So the algorithm that I'm always in search of, I don't think truly exists. You know, algorithms really are a mathematical problem, a computer issue, step-by-step approach. And despite the digital world that we are living in and the ultra high definition digital image that we constantly see in our beautiful robotic view, it is clear that we surgeons still analyze our patients' best interest or choice of operation in an analog fashion. The decision is not just based on digital data. Also, in trying to map out what makes our decisions happen, please consider the possibility that someday maybe somebody like Google can extract the ACHQC data and create a simplified algorithm for patients to decide what operation they think they will need. And when that happens, you thought that your office consultations couldn't take any longer since the media mesh frenzy? Well, just wait till they get a hold of the rhythmic data from our database. The factors that we use to choose the optimal surgical technique are numerous, and some of these are commonly discussed, and others are vague subconscious influences on our decisions, and that also is why there's no simple algorithm. So, of course, obesity has been our long-term enemy in hernia surgery. But what's also of significant interest, especially to me, is the distribution of fat, intra-abdominal pressure related to visceral fat, which can lead to loss of domain and can lead to scenarios of increased abdominal pressure. And patients that might even have the same BMI that have significant extrafascial adiposity distribution of fat, these problems are a different kind of problem, likely more related to wound healing complications. Also, when we evaluate patients, we see people that live, do desk work or do nothing, and then we see these triathletes, which are a huge pressure for all of us as patients. And those patients all demand different things. Then, of course, life expectancy, somebody who has 50 years ahead of them, or somebody who is 95 years old and needs palliation of significant symptoms, where that's the goal and not the durability. And lastly is something that I came up with my small office called the PIA score, not to be confused with other things that are called PIA. And the PIA is a score that we use that we all can kind of be on the same page. Not every patient gets a PIA score, but patients that have some major issue that involves some psychiatric component, their level of intelligence and understanding, or how angry they are from a previous hernia elsewhere. So this specifically is not a judgment of people, but it helps your office staff. Again, not everybody gets this score, but when somebody has significant issues, it's helpful to put in this 3-digit code. So the first variable, what we call the psychiatric, the P, is some degree of mental illness. And unfortunately, there is a huge increase in the incidence of mental illness that we all see in our practice. And we use like a 1 to consider to be some well-adapted normal individual, and a 10 to be some patient who's potentially institutionalizable with severe psychosis. Intelligence, similar, 1 being somebody who has limited cognitive abilities, and 10 being someone who approaches genius. And anger, this is not uncommon. We all see this. These are people that are not necessarily showing anger toward you at your first visit, but you can tell from the minute you walk in the room that there's this palpable anger of what they've already been through with previous failures or complications. And again, 1 is they're totally pleasant and not angry at all, and 10 is severe anger. So the easiest patient to deal with is somebody who, it doesn't have to be the exact, but it's say a 1, 5, 1, so again, a psychiatric 1, intelligence 5, anger 1, those patients are wonderful. And a very difficult person to deal with, and where there's certain decisions you'll have to make based on this, is a psychiatric 10, intelligence 1, and anger 10. So another big part of the potential algorithm of these surgical choice variables, open, laparoscopic, robotic. Do we do it anterior, posterior, intra-abdominal, retroperitoneal, extraperitoneal? Do we use synthetic permanent mesh, absorbable mesh, biological mesh, or no mesh? All of these choices have their own teeth. And then another variable that is very important to consider, because it has a lot to do with patient satisfaction and long-term outcome, is what the patient wants, what they're coming in with their own knowledge. I would say 1 out of 5 of my patients is coming in with a significant component of significant internet level research on what they think they should have for an inguinal hernia repair. And probably 1 out of 3 already at the last minute going to be asking you about mesh, and we all have the same experience. So these are the variables of what a patient wants. The most common one is, I don't want mesh, mesh is evil, and we're all learning to deal with that. We all have our ways to deal with that. Interestingly, as much as I and most of you are loving robotic surgery and its huge advantage and in our understanding of hernias and their anatomy, the patients are rarely, almost never asking for a robotic operation. And then almost never is a patient who's asking to use mesh, despite the most significant data we have in our world of hernia surgery of the use of mesh increasing durability, more than 50% higher than patients without mesh. No one is asking days. So my personal algorithm or decision tree for management of inguinal hernia is clouded by many of these issues. It's clouded by the patient's demands and requests. It's clouded by historical data. And I say historical data, meaning, our, history of papers written in our journals, which are from previous times where we didn't have options like better lighting even, or better communication, or the internet, and of course the robot. And then the third problem that really clouds my decision making is my tertiary hernia practice that many of you also share, where I see a lot of hernia recurrences, a lot of mesh complications, and a lot of unhappy people from chronic groin pain or other problems. So these issues that patients are coming in with also clouds my decision. In a typical surgical day on in a hospital day or an outpatient surgery day, it's even more confusing because I'm, putting mesh in 4 or 5 people, I'm removing it in 1 or 2 people, and then I'm doing a non-mesh repair in 2 or 3 people. It's pretty confusing about really what the right thing is. So when I look at any data that might help me, there's a lot of papers in the recent past about different surgical techniques for inguinal hernia. But I really admire the efforts of the Hernia Med database from Dr. Kerkeling in Berlin. And, this particular paper, he's writing a lot of papers based on that database, which I find quite valuable. Looks at about 2,000 people are involved in each group of Scholdice, Lichtenstein, TEP, and TAP techniques, and he compares the Scholdice to each of them. And I think what's important, the Scholdice being a non-mesh technique, it's not like it showed some extraordinarily higher recurrence rate. It's pretty similar. At the same time, though, it did reveal less pain than an open mesh repair at 1 year. But at the same time, the patients that were operated with the Scholdice technique tended to be younger with lower BMIs and smaller hernias and less risk factors. When I look at my own data, I'm a little disappointed in my own data because I have been quite lax at working hard on getting accurate long-term data. And my data is skewed, as I mentioned previously, by the fact that we tend to enter complications or recurrences a lot more than me talking to people 5 years later with satisfaction after a simple Scholdice repair. So on the first here, we can see the volume that I've had over the last 3.5 years in inguinal hernia repairs. And that doesn't include bilaterals, which is about another 150 cases, and also a lot of open mesh repairs, Lichtenstein and others that I perform. I want to bring your attention to this highlighted area on the bottom, my 2-year inguinal hernia recurrence rate. It says it's 5%, but that's only with 41 people where really I should have been speaking with and following up on 162. And believe me, I am very motivated to work harder on this data for own benefit to see what my best choices are in the future. But to speak about what my little thinking is, what can I give you simply for open inguinal hernia repair without mesh? These tend to be younger, thin people, muscular, athletic individuals with small hernias. I am much happier at doing a non-mesh technique as they are much more body sensitive, and whether they feel the mesh or not, they will think they feel the mesh. Also, people who think who will think about a foreign body implant. When people say, I don't want a foreign body implanted in me, they shouldn't get mesh, because they're going to feel mesh whether they feel it or not, and it's not worth putting it in them. Again, the recurrence rate is not that much higher. I also use it with females with a clear exam of an indirect hernia and an absence of femoral hernia. I've been a strong proponent of the European Hernia Society's recommendation of a laparoscopic approach for inguinal female hernias. However, I've altered things a little bit in terms of how things have changed recently about mesh. So which non-mesh technique do I do? Well, the shoulder ice repair, I choose the large indirect or large direct inguinal hernias, and the DeSarter repair I use less often, but I do use it for small indirect inguinal hernia. So who do I do open inguinal hernia repairs with mesh, Liechtenstein, and other techniques? Mostly older patients, patients that need to be done quickly, patients that I'm palliating a hernia on, patients that are not very active, that are not going to be the typical candidates that are going to have any potential complaint of pain from their repair. So who do I do a laparoscopic total extraperitoneal hernia repair? Now this has been, my main raison d'etre for the last 15 years. I love this operation. I've been through several learning curves. You never stop learning about, the anatomy and exposure and what you're looking at. But I'm doing less of them, maybe because I'm enjoying trying different things. But this is who I do it on still. Patients who are primarily concerned with long-term durability, I'm either doing the laparoscopic or robotic repair, because the posterior place mesh to me makes the most sense. I'm also doing it on patients that have no mesh paranoia, and they just want to get in and out, not a big discussion. It's pretty much typically a laparoscopic TEP for unilateral hernia. Patients with a virgin abdomen, I usually choose laparoscopic TEP over a robotic TAP. Just the theoretical advantage of maintaining the virgin abdomen because of the extraperitoneal approach that I use. Patients that have a likelihood of a hostile abdomen that would require a posterior approach for various reasons, previous open inguinals, I think, I would do them laparoscopic, because this way, that plane is often preserved despite potential for hostile intraperitoneal pathology. And then females not concerned with mesh placement, clearly a lap TEP is excellent, especially because of the possibility of an occult or future effect. So who am I choosing primarily a robotic transabdominal preperitoneal repair on? Well, number one, I'm enjoying them. But number two, people with bilateral inguinal hernias, my neck hurts me a fair amount with laparoscopic bilaterals, depending on whether I not have a second screen for my assistant, and so those I'm pretty much doing robotically. Significant obesity, I think, is easier to deal with robotically than laparoscopically. Patients with a previous prostatectomy who I want to do a posterior approach for various reasons, I'll do them obviously robotic over laparoscopic. Patients who have a need for a previous posterior mesh excision from a previous plug or PHS or laparoscopic, and there's a recurrence, or I'm doing a mesh excision, these patients clearly should be done robotically. And patients that had a previous plug or PHS, the potential for that plug to interfere with the peritoneum posteriorly makes a robotic approach much and enjoyable. So I like, in the end, I like to keep things simple in my choices. I really enjoy hernia surgery, as all of you do, and this.
Well, I'm guessing that came to an abrupt end unexpectedly, but appreciate Dr. Eunice, you sharing the algorithm with us and look forward to hearing a little bit more about the Pia Score in the discussion. The next talk up is lap inguinal hernia repair talk, and will be given by Dr. Veller, who of course needs absolutely no introduction to everybody on the call. And look forward to transitioning from the open talk into the laparoscopic talk. Dr. Veller.
I'd like to thank Mike and Ben and the QC for the chance to speak with you today. They've asked me to speak on laparoscopic inguinal hernia repair. I don't have any disclosures that are relevant to this talk. As Dr. George Watts said, when correctly performed, preperitoneal hernioplasty should prevent all hernias of the groin. This was about open preperitoneal repair, and we certainly want to do that when we talk about the minimally invasive approach, and I think we can after 30 years of working at this. My approach is based on the godfathers of the open repair, Drs. Reeves and Nehus, Watts, and Stopa. I'm not trying to reinvent the wheel. This is based on about 5,000 repairs laparoscopically that I've done since 1990. I started off with the TAP repair in 1990, but as we were able to gain access to the preperitoneal space without entering the peritoneal cavity, I quickly changed to the extraperitoneal approach, since I would learn that as a resident and I liked that approach. I use a 0-degree scope and a unilateral balloon to access the space. Again, you can use manual dissection, but I still like the balloon because it's not bloody and it's quick. I switched to a 45-degree scope for the dissection. Again, you can use a 0-degree scope or a 30-degree scope. I prefer 45 because it allows me to see the things I need to see in this confined space. I use a polyester mesh and fiber and glue for fixation, and I'll go over that in a minute. This is a depiction from Dr. Nehus's third edition of his hernia book of the 1980s of the right side of a cadaver looking from the preperitoneal space out through the abdominal wall. Little did he know that this view is what we are going to do when we do the laparoscopic repair. And he had an illustrator named Roth, you can see on the right there, draw this illustration for his third edition of his book. And that illustration is exactly what we want to dissect when we do this procedure. It's everything we need to see, the direct space, the indirect space, the femoral space, the psoas muscle, Cooper's ligament, all the things we need to see are right there in that illustration. And I think it's something that we need to remember. This repair, preperitoneal repair done open, was first done with mesh by Estrin. He was a US surgeon. Dr. Reeves used a midline incision, and he actually fixed the hernia and then used a unilateral piece of mesh like we use today when we do a repair with mesh. And Stopa actually was the first to not repair the defect and use mesh, but he only did that in his bilateral giant reinforcement of the visceral sac. He did not do that with a unilateral repair, and I'll show you that in a minute. I divide this operation into 3 key phases: the dissection of the retroinguinal space of the myopectoneal orifice of Fouchard, the mesh, and when we talk about mesh, we'll talk about the size, the shape, the material, and the positioning. Those all go into mesh. And then proper mesh fixation, and I believe in that, and I'll talk about that. The dissection of the space, the first phase, is what is difficult for people to learn. And again, I take you back to that illustration I showed from Dr. Nehus's book there in the middle of the screen. We're trying to get to that depiction. And we want to use that dissection to place a large piece of mesh, as the picture on the right, the color picture with the mesh in place. We want that mesh to cover that entire area. The picture you see on the left was from a hernia I did in 1995, early in our experience. However, you can see that I had dissected Cooper's ligament, the direct hernia, the iliopubic tract, the cord vessels, the vas, and the epigastric vessels. Again, early in our experience, but we still were trying to adhere to the principles that were established by the godfathers when they did the open approach. Dr. Jorge Diaz and Ed Felix wrote a paper in the Annals of Surgery in 2016 about the dissection of the myopectoneal orifice, and they wrote 8 to 10 steps that they felt were important to get what they call the critical view of the myopectoneal orifice, and I think it's worth reading. This picture to the right there is Dr. Diaz giving a talk, and you'll see he's has a slide that shows my picture, and it's Dr. Diaz coming to Memphis in the early 90s to learn how to do this operation. And there's a picture of the certificate I gave him when he completed the course. And little did I know he would continue to do so much and be so prolific in this area of laparoscopic inguinal hernia repair. This dissection can be difficult at times. Here's a recent hernia. We've placed the balloon, we've looked in, we've cleaned off the pubic bone. We don't see much else. And what we're trying to do is gain access to the space of Bogris. And you can see in this gentleman, there's a very low insertion of the arcuate line. And so it can be very, very difficult to understand where you are. And when you have this low insertion of the arcuate line, you need to release it. And I start to release it here, but I'm ground out on the grasper. So I switch to a hook to do the release. And now I'm going to release the arcuate line. Now this allows me to get into the space of Bogris. This is a left inguinal hernia. We're looking to the left. I've angled the 45-degree scope, so I'm looking at the upper abdominal wall. The peritoneum comes down, so you want to be careful. You want to go slowly. This just allows me to gain access. I haven't released it enough yet. I'm going to have to release it more. But now I've gained access to the space of Bogris, so I can find the cord structures, indirect hernia sac, all the things we need to see. And you can still see I'm going to have to do more. When we dissect the hernia sac or the peritoneum, I see people be they can be very rough with the spermatic cord. And I recommend that you take the peritoneum and you pull it medially. So it's either the hernia sac or the peritoneum. And when you pull it medially, there's a plane between the blood vessels on the vas deferens and the peritoneum. You can see the grasper here is under the blood vessels of the cord. The white structure is the vas deferens, and there's a bunch of blood vessels that parallel the vas deferens. And that peritoneum or hernia sac will skeletonize off of those blood vessels, so you can sweep that peritoneum back to the level of the umbilicus as you need to do. Again, in this depiction here, I've dissected the hernia sac back. We're back to the left side now. I've dissected a large indirect hernia sac off of the cord structures, but I need to release the arcuate mesh. Again, this is all part of the dissection. That's the blood vessels. That's the vas. You can see the iliac vein down there. The hernia sac's been dissected, but I still need more room. So in this patient who has a low insertion of his arcuate line, I'm going to release more. And you need to take it back as far as you can. Again, the peritoneum has to be swept off the anterior abdominal wall and the retroperitoneum and the cord structures to the level of the umbilicus to get proper dissection of this area. This is on the right side of a patient. This is the psoas muscle. We want the psoas muscle. We want to see the psoas muscle. We want our mesh laying on the psoas muscles. Nothing can come up under the psoas muscle. So if your mesh is laying on the psoas, then you know that you're going to have a good solid fixation of the mesh to the retroperitoneum, and the chance of something coming up under the mesh is certainly decreased. Here's a completed dissection. We're back to the left side now, that same indirect hernia. The direct space is fine. The blood vessels to the testicle. Here's the vas deferens. Here's the hernia sac that I dissected off of the vessels and the cord. You can sweep that back as much as you want. I felt I had enough here to place my mesh. There's the psoas muscle with the nerves, so our mesh will lay on the psoas muscle. And you'll see, I'll look up on the anterior abdominal wall on the left side, and there's the peritoneum. You'll see this white line under my grasper. That white line is the peritoneum. And I'm going to move it back a little more so I can place my mesh. We've created a wide space. We've dissected the myopectoneal orifice very widely. We released that arcuate line so we can get into the space. And now we have a very comfortable space to place our mesh. When it comes to the mesh, again, I go back to how this procedure was developed. Dr. Reeves and Stope and the French, when they developed this repair, used a polyester mesh. And the reason they used a polyester mesh is because it was very soft and it conformed to the contours of the preperitoneal space. I still use it to this day. I like an anatomic mesh, a 3D mesh, since we're covering spaces where there are different planes. And so when you have a 3-dimensional mesh, it can cover those planes that are in different locations, I think, better than just a solid piece of mesh. Now, the softer polypropylene meshes today, the large pore meshes can do a good job too, but I still prefer the polyester mesh. There's 2 sizes I use. 15 by 10 is most common. However, for big patients or big hernias, I'll go to the 16 by 12 because, again, the bigger the piece of mesh, the better. As far as positioning the mesh, again, I don't need to belabor the point. You can see the depiction of the Reeves repair at the bottom of the slide. It's exactly like the color picture I showed of Dr. Wance's repair. We want the mesh covering the entire area with broad overlap of the hernia spaces, the mesh going down over the psoas muscle, the cord structures and the iliac vessels, and up on the abdominal wall. And the picture you see to the right is a laparoscopic repair mimicking that open repair that was developed in the 70s. Not everyone fixates the mesh. I do. My reasons for fixation are multiple. Here's 2 big reasons. The Godfather's Reeves repair on your left. Again, you can see the unilateral piece of mesh, and you'll see at least 15 sutures to 20 sutures holding that mesh in place. He's not relying on abdominal pressure on a unilateral piece of mesh. Stopa on the right side, that's a depiction of his unilateral repair. He used an even smaller piece and he fixed the mesh. All those X's are his points of fixation. That's from Stopa's book chapter, okay? So the non-fixation of the mesh was something Stopa did with the bilateral reinforcement of the visceral sac with a huge piece of mesh, but he firmly believed with unilateral mesh fixation was indicated. In addition, Namir Kikuta, looking at this situation, showed there was significant movement of mesh without fixation, and that fibrin glue prevented that fixation, and that it led to a very strong and fibrous reaction. Kess showed the exact same thing. He saw mesh collapse and mesh protrusion without fixation, and that protrusion and collapse increased as the size of the defect increased. So he felt fixation was very important, as did Schwab. Schwab looked at the same thing in 2008. He looked at no fixation, suture fixation, and fibrin glue fixation, and he saw that the mesh consistently dislocated without fixation. And that dislocation was prevented with either sutures or fibrin glue. The important point was with the fibrin glue, there was the highest stress resistance across the abdominal wall. And it gave the best incorporation of the mesh and the best biomechanical stability. Those are all things that I want in my patient. And so that's why I'm a firm believer in fibrin glue. You can put it on in multiple ways. This is on a right side. This is on a right side hernia, and you can dollop the mesh in place like I do. You can spray it on. I don't think it matters. I just prefer the dollop technique. So this is the finished repair that I showed you through the case on the left side hernia. This is the mesh in place. We've glued the mesh in place with the fibrin glue that's on the psoas muscle. There's the hernia sac, and when we deflate, we'll see that the hernia sac and the mesh will fall up, or the hernia sac and the abdominal contents will fall onto the mesh. The mesh acts like the taco shell, and the hernia sac and the abdominal contents are the filling of the taco to give us a good solid repair. Here's the reason I do this repair. This is a pathologist that I did. He sent me this text, "Are you sure you violated both my groins? I have no real pain. I'm going downtown and sell my narcotics." Here's a surgeon I did. This was in, looks like 2012. "I'm your poster child. I never took one pain pill of any kind. I went fishing on the 4th day. I'm coming in Monday for a follow-up. The backside of my scrotum turned purple. Otherwise, I would hardly known I've had anything done." Again, I think that's why we do this approach. That's why we want to mimic what the Godfathers taught us. And that's why I do what I do with this repair. As Bob Condon said, the high rate of recurrent groin hernias is caused by failure of surgeons to learn a method directly from those skilled in its application. If you want to do it right, learn to do it right from someone who is doing it right. Thank you very much.
one of the things that I've really enjoyed about being involved with this particular summit is the ability to learn something about an operation that I do commonly. So thank you, Dr. Beller, for that. And to our last talk in this section will be by Dr. Anthony Ayako. He is currently at the Michigan Hernia Surgery in Michigan at Beaumont Hospital, and he is going to talk about robotic complex hernia repair.
On complex robotic inguinal hernia surgery, and this is just a snapshot. The objective of this talk is to review recent data that we've published from the ACHQC for robotic inguinal hernia surgery after previous urologic surgery, and the role for robotics in our practice. This is our study that we're going to address today, looking at the outcomes for robotic inguinal hernia surgery after previous urologic surgery using propensity. Disclosure is only that I proctor for Intuitive. Lifetime risk for a male is about 30% for occurrence of a groin hernia. Risk factors are seen here, but importantly, an acquired risk factor is history of previous prostatectomy. Minimally invasive hernia repair, the TAP and TEP techniques utilize a posterior approach to adequately dissect the myopectoneal orifice. These smaller incisions lead to likely less early and late postoperative pain compared to the open procedure and faster recovery. The robotic platform offers improved dexterity compared to laparoscopic in most general surgeons' hands. With an estimated 191 new cases of prostate cancer diagnosed each year in the United States, radical prostatectomy is one of the most common pelvic surgeries seen in the male population. History of prostatectomy is an important acquired risk factor for the development of inguinal hernia. Males who have had prostatectomy have a nearly fourfold increase in the need for hernia repair, with the majority of those occurring within a few years after prostate surgery. Laparoscopic or robotic prostatectomy carries about a 14% rate of post-op inguinal hernia development. In patients with previous prostatectomy, the violated preperitoneal space leads to dense scar formation for any posterior approach, leading to increased risk of bladder and great vessel injury if not careful. The hernia surge group acknowledged this perceived risk in their 2018 international guidelines by recommending that surgeons consider an anterior open approach when performing hernia repair on patients with prior pelvic surgery. In this video, we demonstrate the increased scar tissue seen in a 7-year-old male, history of previous prostatectomy undergoing a inguinal hernia repair. You can see through the medial dissection in the retropubic space the amount of scar. This wasn't a horrible case, but it was pretty dense behind the pubis as commonly found. With the wristed instrumentation of the robot and high definition camera, though, I was able to dissect this space freely in order to provide adequate medial overlap for this right inguinal hernia. We aimed to determine if it was safe to perform robotic assisted inguinal hernia repair on males with a history of previous urologic pelvic surgery. We sought to analyze if there were any increased risk of intraoperative or postoperative complications, or if there were any difference in hernia recurrence or readmission rates compared to those patients without previous pelvic surgery. From the nearly 50,000 subjects at the time of the database submission, we excluded subjects without 30-day follow-up, filtered the query to include only male subjects who underwent robotic inguinal hernia repair. Of the 1,600 patients, we filtered by a documented history of prior urologic pelvic operation and performed a 3-to-1 propensity match analysis to identify a cohort of subjects with no history of prior urologic operation. We used age, gender, BMI, ASA class, nicotine use as our matching variables. Variables of interest collected for both cohorts include basic demographics, comorbidities, postoperative intraoperative complications, including SSI, SSO, reoperations, readmissions, hernia recurrences, and other complications at 30 days. 1,664 male subjects were in the database that had undergone at least one robotic inguinal hernia surgery. 73% of those were over the age of 50 with a median BMI of 27. majority of our study population were never smokers, non-diabetics, and without underlying COPD. The ASA class was 2 or less in 76% of subjects. When comparing the prior urologic pelvic operation group with our propensity matched control group, we can see that the two groups were appropriately matched for BMI, age, ASA class, and nicotine use. There were 0 intraoperative complications, including major vascular or bladder injuries, reported in either group. There were also no difference in postoperative complications. Seroma and hematoma formation were the most common occurrences, but other non-specified complications were also equivalent between the two groups. Lastly, there were 0 documented hernia recurrences reported during the 30-day follow-up and no difference in readmission or reoperation rate amongst the two groups. The use of LAP, TEP, and TAP repair in patients with a history of prostatectomy has been previously studied, and the results suggest that the minimally invasive surgery repairs are a safe, feasible option when performed by experienced laparoscopic surgeons. Given the similarities between laparoscopic TAP and the robotic TAP approach, it is no surprise that our results showed similar findings. The robotic platform offers surgeons enhanced dexterity and wristed instrumentation, which makes dissecting through these difficult scar planes a little bit more manageable. The 3D camera also may improve the surgeon's ability to identify critical structures and avoid inadvertent injury. Although we acknowledge the existence of a learning curve for the robotic-assisted approach, some may argue the learning curve is faster than that of the laparoscopic approach, making the robotic repair more appealing option to more surgeons. There are several limitations to this study. First, the patients were not randomized to receive robotic repair. They were chosen by the surgeon based on characteristics and surgeon expertise, which may have excluded particularly complex patients. In addition, the QC relies upon surgeon-entered data, and some details in the patient's previous surgical history were lacking. For this reason, we chose to include patients with a documented history of previous urologic pelvic surgery instead of specifically trying to identify prostatectomy patients. Furthermore, the contributing surgeons of the QC have a particular interest and expertise in the field of hernia surgery. For this reason, the data may be slightly skewed to represent more experienced surgeons. Further long-term outcomes results are lack. Conclusions from this study. There's no doubt the open anterior repair remains the gold standard and safest operations for patients with a history of previous pelvic surgery. However, in the modern era of surgery where there's a push for minimally invasive options, robotic-assisted inguinal hernia surgery may be safe and effective alternative for patients with prior urologic pelvic surgery who were previously thought to be poor minimally invasive surgical candidate. References are shown here. Now I'm going to transition a little bit to our practice and our take on complex robotic inguinal hernia surgery. Our private practice sees almost exclusively hernia-specific problems. Since about 2015, our approach has incorporated robotics aggressively. Like most practices, we see a wide breadth of disease. Unique to this talk for robotic groin hernia, we have been seeing an increase in complex inguinal scrotal as well as in inguinodynia. We've also pushed the use of robotics in the groin in the setting of complex abdominal wall reconstruction. Here you can see a plug and patch placed about 2 years ago in a middle-aged lady who's been in fairly constant pain in her groin and inner thigh, unable to sit for prolonged periods of time with inguinodynia likely from the plug, the meschoma, as well as involvement of the plug with her genitofemoral nerve. The nice thing about the robotic platform is that it does make taking these out a little bit easier than it was previously, which we would have done with a laparoscopic approach or even open. You can see coming underneath the plug onto the iliacs and epigastrics is much easier, better vision, better visualization with the wristed instruments. Even cutting the mesh in half in order to get a smaller piece to work around the epigastric. This piece, as you can see, goes both behind the epigastrics and both the direct and indirect space. Grabbing the mesh is a little easier with the robotic progress. You can see here, just teasing it off of the epigastrics in pieces. Dissecting posteriorly or anteriorly, rather, around the epigastrics, getting more of the plug out than likely would have been possible laparoscopically only. Here you can see us digging out some of the proline knot stacks as well. And finally finishing off with taking her genitofemoral trunk. This lady woke up with almost minimal pain In this video, we see another mesh resection with ligation of the inferior epigastrix around a fair amount of mesh plug in the groin. We've been seeing an increasing frequency of flat mesh as well, like ProGrip after laparoscopic or robotic repair, with the increasing use of a posterior approach to groin hernia surgery. These are also difficult to resect, but the robot has helped facilitate a better dissection for these complex patients. Finally, for our practice, we will continue to utilize robotics in a comprehensive approach to groin hernia surgery, both the simple and the complex where we see fit. There's been a vast change in approach to the first-time inguinal hernia towards robotics that is becoming a resident's first and most familiar repair upon their graduation, as we've seen. The ability to use wristed instruments to perform delicate dissection where previously an open approach was taken has dramatically changed how we address complex groin disease. Anecdotally, for my partner and I, as well as most traditional trauma surgeons, the ergonomics of sitting have helped our neck and backs as well. As far as the QC is concerned, we need more data analyzing the role of robotics as just a tool for MIS surgery. The robot is not going away. It clearly has a value in our practice, and hopefully the QC and the research arm of the QC can further elucidate its role in MIS groin hernia surgery. Thank you all for the opportunity. I really value this group and this collaborative.
Really appreciate that talk because now I know who to send the plugs to that need to be removed. So just need to get your address in Michigan to where I can send that on up to you. I guess everybody is already on the panel. Dr. Eunice is there. I see Dr. Veller. The first question that we have that came up on the Q&A was, as most talks that include anything about the robot is related to the cost. I don't know if y'all can see that, but just comparing the cost of an open repair versus the cost of a robotic repair, and just asking the question of what everyone's thoughts of that are. So I'll throw that out to Dr. Ayaka since you gave the robotic talk.
No problem. You know, there's an easy way to dance around this, and that I think I do a better robotic repair. If it's more costly, so what? There's no doubt there are local surgeons in every community that are able to go to a surgery center and perform 5 or 6 open repairs and go home by noon. I can't do that where I practice. But I think even working out of a big hospital, utilizing complex and expensive robotic technology, I can still perform a good repair. I'm not skilled as a TEP surgeon like Dr. Voller. If I was, I would probably consider doing them that way, but I get to sit down most of the day to do my repairs, and that has a value. Someone in this group's got to figure out how to publish that and show it to the rest of us.
I had a quick question a personal question for Dr. Eunice. One of the challenges for me in developing my hernia practice has been the ability to maintain expertise across all those modalities, the open or laparoscopic or robotic. So I still do a fair bit of laparoscopic and robotics, but just curious what your thoughts are on that and how have you been able to maintain that expertise in the open repair?
Well, I did train early in my life in the shoulder repair. I don't want to say how long ago, but when they used to call it the Canadian method, you know. Yeah. So it was always part of me. And then another factor is that all I do is hernia surgery, and many of it is primary, and a lot of it is tertiary hernia surgery. So it gives me the ability, and I push myself to, to make the right decision and pick one of the many techniques. And it's amazing how well people do with a simple shoulder ice repair. I don't believe there's any increase in pain when that operation is done perfectly. And I think the obstacle to that operation being done perfectly is mostly recognition of the variability of anatomy, similar to mastering the posterior anatomy. It's not the technical aspects of the operation, it's your ability to really know what you're looking at. So You know, the decision is tough, but I do all of them, and sometimes wish I did did a robotic when I'm doing an open, that kind of thing.
One follow-up question to that, Ron, if I may. So specifically to Jonathan, it's interesting, and this is of prime importance to a lot of patients, especially patients on our patient advocacy committee. There's a general feeling out there that we use too much mesh, and if we can offer non-mesh repairs, there would be more of a market for that. In my own story with the shoulder ice, I actually went up and trained with Mickey Reinhorn in Massachusetts, and he kind of revived my interest in the shoulder ice. And honestly, it's one of the most in-demand procedures right now I do, because patients are just demanding this more and more. The question is how do you successfully teach the procedure? Because it's, I would say, technically a lot more demanding than a lot of the other inguinal hernia operations we do. And that seems to be a big challenge.
Well, I am in a position where I occasionally see medical students, but hernia surgery is undervalued in their education. So I'm really, unfortunately, not teaching anybody. I have no residents or fellows. So personally, I'm not teaching it. Hopefully someday I'll have that luxury. Is that answer? I don't have, is that your question?
Yeah, I mean, you're in a unique situation, but I think it would be great if folks with your experience, especially with the shoulder ice, we figured out a mechanism, especially in the collaborative, to further teach it. I mean, the QC is what brought myself and Mickey Reinhorn together, and he really taught me how to do it. And so, we could use this as a platform for you to teach other folks to do it. Because you're right, when you look at the differences in recurrence, there's not a whole heck of a lot. And even if you talk about a doubling in recurrence, if you look at the absolute probabilities, it's still not that much overall. So a lot of people are willing to sacrifice that for no mesh repair.
Exactly. So, right. A lot of people, we're not treating cancer, or we're not treating, left main coronary disease. So recurrence, if there's a recurrence, it's not the end of the world, but if there's a mesh complication, patients are pretty unhappy. And even though my favorite operation currently is removal of mesh, both anterior and posterior, for the patient, they don't want that problem. And you don't want to have to face, the future of a mesh removal, which is, potentially higher risk of recurrent hernia and ongoing hernia life. But it's a tough decision, and there's no right answer.
I had a question for Dr. Voller, and I'm naive to this, so I really just don't know the answer. When you talk about using fiber and glue, and we started off the conversation today with a discussion about cost, what's the cost of that versus, say, a absorb-attack device?
Yeah, the costs are pretty similar, and it's one of those things that you pick your poison. And since I believe fixation is important, I elect to do it. And I think fiber glue is probably, again, based on the studies I showed you, probably the best way to do it. But the cost is definitely a factor, but it's pretty similar to mechanical fixation. And with the robot and using sutures, sutures aren't as inexpensive as you think. They can cost a bit too.
One quick question for Dr. Ayaka off of the Q&A. Were there any predictors of more difficult robotic repair status post prostatectomy, such as the addition of XRT, extent of lymph node dissection? Seems like sometimes it works out well and other times it's really difficult.
Well, there's no way to tell that looking at the quality collaborative database, because the details just aren't there. Clinically taking these patients to the operating room, it's difficult to tell too. Patients that have had extensive pelvic surgery or node dissection, it doesn't seem to change the amount of scar that they have. It's totally unpredictable. I've probably done, I don't know, maybe between 30 and 40 of these after prostatectomy, which is not that many. I can't seem to figure out who's going to be a difficult case and who's not. Radiation doesn't seem to change everybody in the same way. So unfortunately, it's difficult to predict. I still favor the open approach for someone who's had a prostatectomy. But if they've had a previous open approach and it's recurrent, certainly, I think this data is just more evidence that for those that are comfortable operating in this space, it is perhaps safe for those surgeons to re-op or to go back in the preperitoneal space to perform a good repair somewhat safely.
Follow-up question to mesh removal as well. When you take a plug out and there's a defect that you've left, what do you do with that? Do you do any repair at the time, or do you just see what happens?
Well, it depends on why we're taking it out. Most of these plugs, I think, most of these plugs cause pain, I think, from the mechanics of the mesh contraction and the location and the size in which, or place in which they were placed. The video I showed there was a skinny woman with a huge plug. There's no doubt moving her leg is difficult, and the mechanical effects of the plug would be mitigated by removing it. So I did not put a piece of mesh behind her. She still has a patch in front. So I think that indirect space is relatively protected. If she were to develop a hernia again, there's just a hole in the peritoneum that was easily closed. Could easily go back in the preperitoneal space to repair her. Traditionally, these patients do not want you to put another piece of mesh inside of them. I'd much rather go back and fix a hernia in any other method than to have them have continued pain and suspect that it was my repair causing that pain. So I would leave it alone. I don't know if any of the other panelists would handle that differently, but.
I tend to, it's my personal philosophy to not put mesh in when the indication was for chronic pain, because in the patient's eyes, it's from the mesh, even if it might have been a small recurrence. So I tend to not put mesh in, make their expectations well known about the potential for future recurrence, and then close the defect with a long-term absorbable suture, understanding the anatomy and what you're closing. And then, and my results, in doing this is really only looking at about 2 years. And it's remarkable how few over 2 years of recurrences that I've seen, but I'm sure they're going to start coming, and they'll get a more proper repair when they present.
Well, I've gotten the message from Eileen and Ben as well that we need to wrap up. So I appreciate everybody's involvement, and back to you, Ben.
Yeah, thanks everybody. Great session. I want to thank Ron for moderating and all the presenters. Fantastic discussion. Keep in mind, this will all be recorded and will be available online once we're done here today. So we'll take a short, let's take about a 5-minute break. Be back maybe about start at about 50 past the hour, 50 past the hour. We'll be back. So a short break. We'll be back in a little bit. Okay, folks, it's 50 past the hour, and we've reached our final session here, concentrating on ventral hernia repair. We've got a great set of moderators and panelists for a pretty robust discussion, just like we had for our inguinal session as well. I'd like to remind everyone, in between the sessions or at the conclusion of the ventral session here, please look at the rolling images that are going to be on the screen. There's a couple of surveys and some information for you in terms of coaching opportunities, physical therapy survey, and also a way how we can increase our participation in the QC. And here they are. Oh, great. Awesome. And so first is our QC membership drive. And you can basically scan that QR code to just download a really easy to use flyer to give it to folks. Oh, thanks, Aileen. Great. Download this and you can get the flyer. And also here's some additional information on how to increase our participation in the QC. You all are a big part of this, and a lot of this is word of mouth. Even if you were able to get an additional surgeon to participate, that's a big victory overall. And then finally, there's a link to a survey about how you use or don't use physical therapy in terms of incorporating this into our practice. So thank you. And so I'd like to introduce our moderators for the upcoming session here. Drs. Winnie Henderson and Dr. Roxanne Liu, both from the West Coast. Dr. Henderson practices in Oregon, Springfield, Oregon, and Dr. Liu practices in Oakland, California. And they'll be kicking off and moderating our ventral hernia session. Thank you.
Thank you. To start off, I think, Eileen, we are going to present to you a couple of questions on the physical therapy survey. I'm part of the ACHQC Quality Improvement Committee, and we have been thinking about it would be a good idea to investigate the role and the use of physical therapy in the outcome of our patients. And we actually would really love the information produced by the participants of the ACHQC to see if anybody use physical therapy and recommend referral to their patients. And if you can take the time to kind of answer these couple of questions. Additionally, the survey will be sent to email or already have been sent to email to ACHQC members so that we can collect more information, and just want to encourage you to participate in this, and that might improve the data that we would have for the quality improvement community. So thank you for that. And I am going to introduce our high performer for open ventral hernia repair talk, Dr. Clayton Petrel. He is a assistant professor of surgery for Lerner College of Medicine and Cleveland Clinic. Dr. Petrel.
Hi everyone, thanks for tuning in. My name is Clayton Petro from the Cleveland Clinic, and I'll just start by saying that in the virtual presence of a lot of surgeons with a passion for hernia surgery, it's certainly an honor to be considered a top performer of anything. And so hopefully by virtue of having done a lot of this in a relatively short amount of time, I'll be able to provide some tips and tricks and some lessons I've learned over my first few years of practice. Okay, so for me, open ventral hernia repair is going to be a retromuscular technique in the vast majority of cases. And just as a consequences of the cases that we see, about 98% of the time, that's going to be a TAR. And so that's really going to be the focus of my presentation. Now, our saying at the Cleveland Clinic when we have an unfavorable outcome is to just increase the denominator. So when I felt like I was having a lot more wound morbidity than my partners in my first 6 months, the only solution I was really offered was to just keep operating. And that's probably how I ended up doing almost 200 TARs in my first 2 years. And there's no question that in that time, there have been a lot of humbling experiences and growing pains. And one of the things that's evolved is I've had the unique experience of, starting my practice along 3 partners who do the same thing at a high volume. It's my perspective on wound morbidity, why it happens, why it seems to be more consequential for some surgeons more than others. And I don't think there's anything that I'm going to say that's going to be revolutionary, but I'm going to try to articulate the way I think about wound morbidity and how it relates to a lot of the decisions I make about who to operate on, and why some of that decision making has really changed over the course of time. And then I'll follow that with some small intraoperative tips and tricks that I've learned along the way. So in the grand scheme of things, I think that anyone who does this stuff at high volume is going to see some variable range of wound morbidity. And that could be a consequence of a lot of different things that we're going to talk about. But at the end of the day, with monofilament polypropylene mesh in the retromuscular space, a lot of times wound morbidity can be overcome without excising mesh, and actually most of the time without an operation. And for those wound events that do resolve, I think it's pretty reasonable that patient can still expect a durable repair. But when we really get into trouble is when wound morbidity leads to exposed mesh and that mesh doesn't incorporate, and that ultimately requires mesh excision and essentially leaves the patient with the ability to expect an inevitable recurrence. So with monofilament polypropylene mesh in the retromuscular space, how do we get to a situation where you need to potentially excise mesh? And I essentially have a 2-hit hypothesis for this. And the first part is the part that we are all familiar with and we obsess about, and that's superficial and deep surgical site infections. And for the most part, these are where all the usual suspects come into play: smoking, poorly controlled diabetes, elevated BMI, the presence of contamination, the size of the hernia. We love to discuss whether or not certain factors are more important than others, whether or not chlorhexidine matters, or how long people need to stop smoking. And I'm sure we all have kind of our own algorithm or cutoffs framed around whatever conversation we have with the patient that describes realistic expectations and also lets us sleep at night. But when wound infections happen and we get them under control with antibiotics or debridement, we are occasionally left with exposed mesh. And even in these situations, it's not unusual for the mesh, to pretty much granulate in. But when it doesn't, what's odd to me is that the discussion usually transitions to what? The mesh. These get classified as complications of permanent synthetic mesh. But that doesn't really make sense, because the minute the fascia comes apart, and you're left with essentially a bridging scenario with exposed mesh, oftentimes we like to talk about whether the use of a bioabsorbable or a biologic mesh would have made a difference. But really, all that does is save you the step of having to cut out your unincorporated mesh. Either way, to me, you're going to be left with an inevitable recurrence. So what we should really be talking about is why the mesh failed to incorporate. And typically, to me, it's because of one of 3 reasons. The peritoneum, or the posterior sheath underneath that mesh, is necrotic because it's not granulating through. There's vicryl mesh underneath, which isn't going to incorporate through for the most part. Or your synthetic mesh that you placed isn't flat. And what's interesting about those things is they're all things that we can potentially control. So when the discussion moves away from the mesh and we start to talk about what we can do better as surgeons, that's where this it's really interesting, because a lot of these things are technical and they do seem like things that we can maybe control. In terms of superficial wound morbidity, I do think that having an efficient operation and doing these operations as you do more and more of them and you get quicker, I do think that having a shorter operation matters. And I also think that when you're more conscientious of taking some of the perforators off the epigastric, that makes a huge difference. In that vein, having to clip or ligate an inferior epigastric artery, to me, is probably just as consequential as having an enterotomy. And so when you consider the real estate that is supplied by an inferior epigastric artery, I really believe that taking these leaves you vulnerable to wound morbidity. And as far as preventing ischemia to your posterior rectus sheath or peritoneum, I also think that as you become better at this operation, you make fewer holes, and you're less likely to have those areas of posterior sheath necrosis. That's going to be certainly helpful. in those rare scenarios where you do get exposed mesh. Now, to be fair, no one really understands where the blood supply is to that layer after the dissection. And I have to believe that, just having an intact posterior sheath at the end of your operation does make a difference. For larger repairs, and particularly redo TARs, I also prefer to use omentum over Vicryl. And so in the rare instance where you can't get the posterior sheath closed, I do think, again, in the rare instance that you have exposed mesh, having omentum underneath your mesh is going to granulate through a lot better than a piece of Vicryl mesh. And then finally, making sure your mesh is flat at the end of the operation will definitely help you in the rare instances, again, where that mesh is exposed. If it's not flush with whatever's underneath it, it's not going to incorporate. And so when I was watching my partners, get away with operating on 20 centimeter defects in actively smoking patients with a hemoglobin A1C of 10, the only way I was able to reconcile that was to acknowledge that a lot of the optimization parameters that we discuss are a bit of a moving target because we ourselves are a moving target. And this is something that you can learn as you look at your own data through the ACHQC. I have the fortune of watching my partners right next to me, but this is what the ACHQC allows, is it allows you to see where others are at. And I do think that if you see kind of where you fall next to others, and you might talk to others and find that they have different parameters than you, I do think that if you consider that there is a technical component to this, and that the better you get, that some of these things might not matter as much, I think that allows you to kind of reconcile that discrepancy. So today, my parameters might be a little bit different than what they were, when I started. When I started, for instance, my hemoglobin A1C cutoff was probably closer to 7. But again, as I did more and I became more efficient, I started to loosen that a little bit. For BMI, usually my cutoff used to be 35. Now I've tailored that a little bit. So if they don't have a lot of subcutaneous fat, let's say they've lost a lot of weight up front, or if the hernia is not quite as large or complex, I might be a little more willing to go to a BMI of 40 or even above. As far as smoking, I do tell them to quit 4 weeks before surgery. And then I point to the exam room or the exam table in the room that we're sitting. And I say, hey, listen, if we're sitting here 3 weeks after your operation and I'm opening up your wound with pus pouring out, I just want you to remember that we had this conversation if you decided to cheat. And then I usually will say something like, I shouldn't care about, your outcome more than you. You should care about it, just as much as I do. And then as far as like my, size parameters, usually defects greater than 7 centimeters are usually for the most part going to require a TAR, not always. Sometimes you can get away with a Reeve Stopa. And then I do, as I start to do more robotics, my 7 to 12 centimeter defects without previous mesh, I'll usually cherry pick and attempt them robotically. All right. So now we'll get into some intraoperative tips and tricks. So as I mentioned before, I do think that controlling what perforators you take and keeping this dissection dry is probably more consequential than just preserving the innervation of the rectus when we talk about preserving perforators. Particularly with working with residents, we make a big deal about pulling hard with your left hand on the posterior sheath as you dissect. But one of the things that drives me crazy is when they pull really hard and they just tear a bunch of perforators off of the epigastric. These can be really hard to control, and a lot of times this may end up to you needing to ligate the epigastric. And so I really think that maybe focusing not so much on pulling hard on the posterior sheath, but to set the tension and to be dynamic, and as you advance throughout laterally, to gradually pull harder. Another thing that I've learned in regards to just being efficient with doing these is that if you have a big piece of intraperitoneal mesh, you're probably a lot better off just leaving it on and doing your TAR dissection, particularly if the mesh is tacked lateral to the semilunar line. If you try to peel that off before your TAR, you're just going to make a bunch of little holes that you're going to encounter as you develop your preperitoneal plane. And those holes beget larger holes, and it just gets a lot harder to control. So just leave the mesh on. And at the end, when you're done with the TAR, it's a lot easier to figure out what you can take off and how thin that layer is, and how easy it'll be to preserve your peritoneum. Another thing that I think most descriptions of this is the one video that I have. Another thing that most descriptions of this operation don't really emphasize is the importance of being in the correct retroperitoneal plane. So you'll see here, I'm pushing some retroperitoneal fat off of the peritoneum. And this will get you in the lower third of the abdomen to the psoas muscle. You'll see here, you should be able to push a lot of this retroperitoneal fat off of the peritoneum. The tempting thing is to peel that fat off of the muscle. That's not the right thing to do. And if you do that, a lot of times you'll get into bleeding back there. And I do think that leaves you prone to postoperative bleeding afterward. And so if you peel that retroperitoneal fat off of the peritoneum, not only does that get you the psoas muscle in a much drier plane, it also liberates the peritoneum quite a bit. And so for your larger TARs where you need a lot of posterior sheath advancement to get the posterior sheath closed, this will help a lot. And a lot of this bleeding, if you do get into bleeding back here, a lot of it's just venous oozing, but we have started to use really aggressive regimens of DVT prophylaxis, Lovenox on the night of surgery. And so, I have started to use green and blue clips. If I see something, I will clip it. If it's just oozing, a lot of times you just kind of have to deal with it. You have to throw a pack back there. But if I do see something, I've started to clip them. And I do think that helps a little bit. These are just a short list of my own quirks. Maybe not so much for like the 2.5 hour TAR, but if it's a 4, 5, 6 hour case, I do change gloves. It's one of those things that, it couldn't hurt. It's cheap. Like I said, we use pretty aggressive DVT prophylaxis, including Lovenox the night of surgery. And I think, we've all been burned by this in terms of bleeding. And so I usually do take a lap that involves just looking at both epigastrics. And this does seem to be the most common area of a take back is an epigastric. And so if you're going to look at one thing, just look at the inferior epigastric, because that's usually where you'll find something worth clipping. And then I also look in the subxiphoid space, because there's always little branches right under the xiphoid that tend to tear and like to bleed. And then I look at both drain sites. For closing the midline, I probably close with figure of eights 80% of the time. I think part of this is tension, which is usually what the reason that we talk about. But to be honest, the other reason is just a lot of times with multiple redos, the fascia is just crap. Not always obvious, where the scar plate ends and the fascia begins. And so usually if I do decide to run it, it has to be under a reasonable amount of tension. I have to think the fascia is of good quality, and I can see the fascial edge along the length of the wound. I have a very, very low threshold to leave a subcutaneous drain. If there's any dead space at all, I'm usually going to leave one just because it feels like you really don't lose anything. You're leaving drains anyway. Leaving an additional one doesn't seem like a big deal. And if they have any wound cellulitis, you already have that space drained, and you don't really have to worry as much about leaving it. And it's on top of your fascia, so you don't have to worry as much about contaminating your mesh. You can leave that draining until it's bone dry. Again, that's anecdotal, but I feel like it's kept me out of trouble every once in a while. So in conclusion, I do think it's important to recognize that everyone has some variability in regards to their thresholds. And I do think that, if you're looking at your outcomes in the QC, like I did early on, I really felt like there were things that I couldn't get away with that my partners could. And so the only way I was able to reconcile that were to focus on the things that I could do better in the operating room. And I do feel like that's allowed me to catch up, so to speak. And I think if you kind of focus on those things, that you'll find that some of the other things, as far as pre-op optimization patterns, there can be some flexibility. So thank you. And I look forward to your questions.
All right, thank you, Clayton. That was a wonderful talk. Thank you for being honest and also giving us a lot of tips and tricks that we can apply the next time we perform a ab wall reconstruction. Next, I would like to introduce Whitney Webb from Piedmont Athens Regional Medical Center in Athens, Georgia. And he is going to talk about robotic ventral hernia repair, a topic near and dear to me. So Whitney.
Hello, I'm Whitney Webb. I'm a general surgeon from Athens, Georgia. I'd like to thank the ACHQC for asking me to speak on a topic I'm very passionate about, robotic ventral hernia repairs. I have no disclosures. This is my robotic experience. I started doing robotic surgery back in September 2016. As you can see, I primarily do hernia repairs on the robot. I've been very fortunate out of all these cases. I've only had to convert 3 cases to open procedures. When the ACHQC asked me to give a talk on robotic ventral hernia repairs as a high performer, I had to think a little bit about exactly what do I do that would put me in this type of category. And this is sort of the chart that I came up with. As you can see in the center of the chart, it's robotic surgery. I do think that robotic surgery is a fantastic platform that, if it's done correctly, allows you to do high quality hernia repairs. I think that robotic surgery is a good marriage between minimally invasive techniques and open operations and techniques we learned from that. And I think that as a tool, robotic surgery allows you to have incredible visualization, as well as it gives you the dexterity to do fine dissections on complex hernia repairs. Around robotic surgery, there's 4 categories that I think is important as well. These are preoperative selection, patient education, consistent team with efficiency, and technique that you use. Preoperatively, I do a lot of the same screening that most people do. In my diabetic patients, we look at the hemoglobin A1C. I usually use 8 as a cutoff. Anything above 8, we delay elective surgery, and we work with primary care doctors to try to get it below 8. We look at the BMI for any morbidly obese patients, go through the appropriate preoperative weight loss education, and we talk about comorbidities involved with their BMI, with recurrence rates and complications after surgery. And then we also do the appropriate cardiac and pulmonary clearance. I think that patient education is a very important part of this whole thing. I give each of my patients a detailed patient education packet that I put together when they first come into the office. We go through a full explanation of what a hernia is and how it's going to be repaired and the different options they have for having it repaired. We go through all the surgical instructions, and then we go through the post-operative restrictions. Also come up with a custom plan for resumption of normal activity. This can be different for each individual patient. I have some patients who are manual laborers, and if they don't get back to work, the family doesn't eat. And then I have other patients, like an 85-year-old gentleman who's retired, and their goal is to get back to the golf course playing golf. Go through a plan for pain control. This centers around, first of all, early ambulation, having patients getting up, walking day of surgery. Recommend use of ice. And then as far as pain control goes, recommend as the first line of treatment is Tylenol first. Recommend alternate this with either ibuprofen or Lee, and then using narcotics as a secondary option. I do think that the narcotic discussions we had back in the 2019 meeting had a fairly big impact on my practice personally. I do feel like I probably was giving out too many narcotic pills at that time. At this point, usually if we do give narcotic prescriptions, it's 5 milligrams of oxycodone with a maximum of 10 pills per patient. And then we go through realistic goals for surgery. Tell the patient that they are going to have an operation, that they are going to have pain in the post-operative period, and what they do after surgery directly relates to how quickly they get over that pain and how quickly they get back to a resumption of normal activity. And then we also come up with a plan for follow-up and as well as participation in a CHQC program. I do my robotic ventral hernia repairs. I use the IPOM technique where the mesh is placed up underneath the peritoneum. This is a typical room setup we use for the robot. Typically, I place the robot on the left side of the patient, unless the hernia dictates differently and we have to go to the right side. This is patient setup. Patient's in the supine position. We do flex the bed. We have the arm that's out. Typically put a roll on the opposite side of where the robot docks. As far as trocar placement goes, if the hernia is in the center of the abdomen, I usually place an incision up in the left upper quadrant. This is a muscle splitting incision through the rectus muscle. And then put a port in the left lateral medial location in the left lower quadrant. This is a typical setup for a trocar placement. That top trocar is a 12 millimeter port that allows us to place mesh and needles inside of it. And then the other 2 ports are 8 millimeters. Type of instruments I use a Cartier and monopolar scissors for dissection. I use a mega needle driver for sewing in the mesh. And then I use a laparoscopic grasper for placing the mesh inside the abdomen and placing needles and removing them from the abdomen. Always do a tap block laparoscopically before docking the robot. I think this plays an important part in direct postoperative pain control, as well as see the effect of less nausea in the first 24 to 48 hour period after surgery. Now, preparation at the very beginning of the operation, I think this is one of the most important things to do is to prepare to do your hernia repair. I think it's very important that you get all this fat and everything that stuck up to the abdominal wall cleaned off and define your fascial edges very well. This also can be the most difficult portion of the operation if you're dealing with adhesions or old mesh in the way. As you're seeing here, I'm taking down the median umbilical ligament and the umbilical folds. So the mesh is going to lay nice and flat up against the peritoneum and the abdominal wall. And then you can see above here as well, the falciform ligament is actually stuck up inside a second hernia defect right here. And you're going to be seeing us reducing that fat out of that second hernia defect above the umbilicus. And then once we get all that stuff dissected out of there, we'll continue to take down the falciform ligament. And again, this gives us a nice flat, even surface to be able to lay the mesh directly up against the peritoneum, and gets us ready for fascial repair. Fascial closure, I use a 0 V-lock running suture. I usually finish the suture in the middle of the repair, and then I use that same suture to parachute the mesh up against the anterior abdominal wall. And then we go into suture to mesh. Typically, I start with my first suture caudally in the midline. I'll take that same suture and throw it in the same direction twice. Once this suture is in place, then what I'll do is I'll go to the other side of the mesh, and we'll go cranially. We'll put a second suture in there. And by doing this, this really has the mesh laying nice and flat up against the anterior abdominal wall. And that way you don't need to use any type of mesh deployment systems or anything like that. So to do the same thing here, where we throw the suture in the same direction twice. And then when I go to advance on the mesh, what I'll do is I'll go in at a 45-degree angle. And as we come out, we'll go directly 90 degrees back, and then we'll continue to advance at a 45-degree angle around the mesh right here. And by doing this, that has that mesh laying nice and flat up against the anterior abdominal wall. As you see, as we start getting towards the other suture, what I'll start doing is I will reverse the direction of the suture here, but I'll continue to advance on the mesh. And what this allows to do is it allows you to lock that V-lock, and then, but you're still making advancement on the mesh. And so after that, we'll continue on with our second suture, and we'll suture all the way around to the other side of the mesh. This is an 8-centimeter piece of mesh. Typically, any mesh that's 11 centimeters or larger, I will run a suture down the midline of the mesh as well, just to help hold that mesh up against the anterior abdominal wall. And as this is playing, I'll talk a little bit about the next slide. So in the postoperative period, typically what I'll do is I'll call my patients at home the day after surgery, check on them, see how they're doing, make sure that they're up ambulating, using ice, and just make sure they don't have any questions about any postoperative restrictions or their plan for pain control. Then I'll see the patients back in the office at 2 weeks. At 2 weeks, what I'll do is I'll start getting them back, doing some light lifting at that time, and basically sort of use their own judgment of how well they're advancing, of how quickly they return to normal activity. Usually I tell them it's about 3 to 4 weeks before they get back into normal activity. I do want them lifting at home to sort of simulate what they're doing at work first, so they're not trying to lift for the first time in a work environment. And then we see the patients back at 6 weeks and just make sure that they're back to normal activity and that they're everything is healed up and they're not having any problems. And then we talk about continued follow-up with the ACHQC, that they'll be either getting a phone call or an email with continued follow-up with their hernia repair. And then the last thing is, I think it's very important to have a great team that you work with. I've been very fortunate to have a fantastic team that I've been working with. Consistently the same people every time. They have incredible turnover time. and they do a great job docking the robot. Usually they can dock the robot in less than 2 minutes, even for complex hernia repairs. I've also had the same first assist that started doing the training back with me back in 2016, and she's done all the cases with me. And I really think that it not only makes the surgeon's life a lot better, but it also makes her environment where I do think it helps out in the quality of the patient's care as well. I'd like to thank everybody for listening to my talk. I look forward to the panel coming up here shortly to answer any questions. If you don't have an opportunity to ask me any questions during the panel time, feel free to send me a message or to call me. My contact information is on the HS website, and I look forward to talking to you. Thank you.
All right, thank you, Whitney, for sharing with us how the best of the best does it. Next is Ragnar Peterson from Ascension Medical Group Via Christi Clinic in Wichita, Kansas. And Ragnar is going to tell us about robotic ETEP compared to open repairs. Ragnar.
All right. Hello. My name is Ragnar Peterson. I practice in Wichita, Kansas. We're going to talk today about a QC study that we did in regard to robotic retromuscular hernia repair compared to open hernia repair. And if we have time, discuss a little bit about our experience here in Kansas in the wheat fields. I have no pertinent disclosures. By means of introduction, certainly open retrorectus hernia repair has been associated with lower recurrence rates, lower wound morbidity, and generally better patient satisfaction over several decades. Over the last few years, evolving techniques in both laparoscopic and robotic surgery have made minimally invasive retrorectus repair not only possible, but popular. What we initially set out to do, and what we do in our center, we do a fair number of robotic enhanced view totally extraperitoneal repairs. And what we wanted to try to do was to evaluate the approach of ETEP versus the open counterparts, not only for straightforward hernias, but also for hernias that required posterior component separations. And what we discovered was that it was difficult to determine the type of approach using the QC format. For example, a robot transabdominal TAR and an enhanced view totally extraperitoneal TAR both divide the same fascial layers. And while there are probably some nuances that we could have explored to try to suss out which was which, it became very labor intensive. So we decided to modify the way we looked at it. And what we ended up doing is comparing all the different mechanisms of robotic retrorectus repairs to their open counterparts to see what, if any, differences in postoperative outcomes could be elucidated. Neither one of these groups, or rather in these two groups, none of the patients got posterior component separations. So no TARs were performed in either the open or the retrorectus group. Conventional wisdom would imply that minimally invasive surgical approaches have several advantages over their open counterparts in regard to length of stay or wound morbidity or postoperative pain. And we really wanted to see if we could closely match the groups and determine if there was truth to that or not. So this was a retrospective pooled data analysis from the QC from 2012 to 2020. Inclusion criteria were pretty straightforward. Again, no posterior sheath, no transverse abdominis releases were performed, but posterior sheath releases were present in all patients. When we went to propensity scoring matching, we really wanted to try to match these groups up as evenly as we could. So we matched according to ASA score, comorbidities, BMI, hernia width, gender, race, history of abdominal wall SSI, OR time, and recurrent hernias. And what you see at the bottom of the screen there, we ended up with 597 patients in the open group and 392 in the robotic retrorectus group. So we were very balanced in regard to race and ASA class and comorbid conditions. Our average BMI for the study was 33. Interestingly, 85% of the robotic retrorectus repairs were performed within the last 3 years. and 7% of the robotic retrorectus patients had inguinal hernias versus 2% of the open cases that were repaired concomitantly. In regard to wound classification, certainly the open group ended up with more clean contaminated cases, and more dirty infected cases. In regard to demographics, the open group had a statistically significant greater number of patients who had had a history of an open abdomen and history of component separation, possibly suggesting a higher degree of complexity between the two patient groups. But in regard to history of abdominal wall, surgical site infection, and MRSA infection, there was no statistically significant difference between those groups. In regard to hernia types, the majority of hernias in both groups were incisional. Approximately 30 and 35% retrospectively were recurrent hernias, and the average number of previous repairs in each group was 1. So both in the unmatched and the matched data, the operative times were about the same. One of the things that you always hear about the robot is that it takes longer to perform these operations. Well, in this study, in the unmatched data, that doesn't necessarily correlate out. Certainly, there were more grade 3 hernias in the open population and more grade 2 hernias in the robotic retrorectus population. A concomitant procedure was performed in 9% of the robotic retrorectus repairs and 32% of the open repairs. The most common concomitant procedure for the robot group was a hernia followed by a hepatobiliary or pancreatic procedure. And the most common concomitant procedure in the open group was a GYN or a colorectal procedure. In terms of intraoperative complications, there was a statistically significant difference between the robot group and the open group, with the open group being more likely to have intraoperative complications. The most common intraoperative complication in both groups was a bowel injury. There was no statistically significant difference between hemorrhage or requirement for transfusion in these groups. Again, no significant differences between dimensions of hernia and the mesh placed. Both were able to close the fascia greater than 98% of the time. However, the open group did require 4% of those patients having additional external abdominal oblique releases. In regard to follow-up, length of stay was 2 days shorter in the robotic retrorectus group. Both groups had a similar readmission rate. The most common reason for readmission in the robot group was a wound complication. The most common reason for readmission in the open group was a GI complication. Readmission for wound infections occurred in 5 of 392 patients in the robotic retrorectus group and 10 of the 597 in the open group. 2% of those patients required return to the operating room in the robotic retrorectus group, and the most common reason was a bowel obstruction. The same percentage and reason is also true in the open group. These were not statistically significant differences. In regard to surgical site infection, there were no statistically significant differences in the overall SSI rate between the two groups and the type of SSI that occurred in the two groups. The only statistically significant difference in these categories really came for treatment of superficial surgical site infections. The open group was much more likely to be given oral antibiotics than the retrorectus group. There were no other differences between the two. In regard to surgical site occurrence, there was a significant difference between robotic retrorectus groups and the open group of patients, in that the robot group more often had seromas. However, they were much less likely to require treatment than when seromas occurred in the open group. In regard to pain, there was no difference between the two groups in requirement for additional pain control or additional pain-related intervention. So points of discussion in regard to this data, I felt as though it was a relatively balanced head-to-head comparison. Open procedures appeared to deal with slightly more complex disease. They had a slightly higher risk of intraoperative complication. There was no overall difference in OR time, fascial closure rates, mesh size for similar hernia sizes. Readmission and return to the operating room was not statistically different. Robotic retrorectus repair discharges 2 days earlier than the open repair on average. There's no difference in the overall SSI rates, but open repairs get more oral antibiotics. You're more likely to get a seroma with a robotic retrorectus repair, but it is less likely to require intervention than when it occurs with an open repair. In regard to our personal experience, we've been doing ETEP since 2017. We have a block of patients that we've been studying, 47 patients that are between 1 and 2 years out from an operation. Our traditional indications for robotic ETEP have been ventral or incisional hernias greater than 5 centimeters, a history of multiple failed procedures, particularly IPOM, or hernias that are in different quadrants. So of that 47 patient block, we've had 2 readmissions. One was a local hematoma in an anticoagulated patient on postoperative day number 4 at a 12 millimeter port site. It didn't require any intervention other than local cauterization in the ER. We also had a PE on postoperative day number 18 and a separate patient. In regard to reoperation, we've had to take 1 patient back for bleeding on post-op day number 1. He was discharged on postoperative day number 2. Our average BMI is 33. Average hernia length is 6.3 centimeters, with the long in the group being 14 and the short being 2. Average hernia width is 5.6 centimeters, with the widest being 10 centimeters and the shortest, or the narrowest, being 2 centimeters. Mesh length, you can see those numbers. The longest mesh we put in is 45 centimeters long, the shortest is 25. Mesh width is 21 centimeters in average, with a long of 30 and a short of 13. Our patients have had an average of 2.6 abdominal operations before they get a hernia repair from us. 12 of these patients in this group required unilateral bilateral TAR. 19 of these patients required concomitant ventral hernia repairs concomitant inguinal hernia repairs in addition to ventral or incisional hernia repairs. 18% of these patients were presented with recurrent hernias initially. Our average intraoperative blood loss is about 20 centimeters. Our average hospital stay is 1.2 days. Most of our patients take about 5 pills or less on average, and we have 0 known recurrences. So that's what we have to present. We appreciate the time and the opportunity to be here. Thank you very much, and we're happy to take any questions.
Dr. Henderson, you're on mute.
Okay, I guess I was on mute, technical difficulty. I was saying that, Ragnar, that was a wonderful talk, and we'll probably save the questions for the panel session. I'm going to introduce Katie, and I hope that I'm not going to say your last name incorrectly. Is it Monteleone? Katie Monteleone is a research resident at Cleveland Clinic, and she's going to talk to us about flank hernia repair today.
Today, I will be discussing I am a general surgery resident at the Cleveland Clinic Foundation in the Center for Abdominal Core Health. Today, I will be discussing an algorithm for repairing flank hernias. Dr. Rosen received salary support for his position in the leadership of the ACHQC, which is the source of the presented data. Other disclosures are listed here. The European Hernia Society defines flank hernias as defects occurring in the L2 region, bounded medially by the lateral edge of the rectus sheath, laterally by the anterior axillary line, and craniocaudally by transverse lines 3 centimeters above and below the umbilicus. While this definition seems straightforward, flank hernias can involve other regions and may be in proximity to bony landmarks and neurovascular structures, which can create unique challenges. Likewise, there is no shortage of repair options. Surgeons have described effective results with open and minimally invasive repairs. Some approach these hernias similarly to ventral hernias, with the patient supine, while others prefer to place the patient in lateral decubitus. And for open repair, there are multiple arrangements of midline and lateral incisions. Midline incisions allow one to access the medial aspect of the flank defect and the contralateral side of the abdomen, while flank incisions optimize access to the lateral aspect of the defect and to the retroperitoneum. For all of these decisions, if you choose wrong, you can't expose the most challenging areas of the repair. We hypothesized that there is a size threshold at which open repair becomes preferable to minimally invasive options. We also hypothesized that isolated flank hernias and those with a concurrent midline defect require distinct approaches to maximize surgical exposure and potential for adequate mesh overlap. And lastly, we hypothesized that the most challenging part of the case changes depending on how far the defect is from the midline. We set out to describe how these hernia characteristics, which can be defined preoperatively on imaging studies, influence our operative decision-making, particularly operative approach, patient positioning, and incision location. We use the ACHQC registry to retrospectively review flank hernia operations performed at the Cleveland Clinic Center for Abdominal Core Health over a 5-year period. We queried the ACHQC for adult patients who underwent elective repair of L2 defects and had 30-day follow-up, and then excluded patients who had peristomal hernias or did not have preoperative CT scans. Using these parameters, we identified 85 patients. The etiologies of flank hernias were diverse. Isolated defects most frequently resulted from urologic surgeries, while flank hernias with a concurrent midline defect most frequently resulted from colorectal and liver surgeries. For isolated flank defects, the operative approach taken was related to hernia size. Isolated defects less than 10 centimeters wide were repaired with both open and MIS approaches, while those greater than or equal to 10 centimeters wide were nearly always repaired open due to the technical challenges presented by the bony and neurovascular structures located adjacent to the defect. For isolated flank defects, the patient position was related to the distance of the medial fascial edge from the midline. Isolated defects within 12 centimeters of the midline were usually accessible with the patient supine. However, those greater than or equal to 12 centimeters from the midline were nearly always repaired with the patient in lateral decubitus, because otherwise it would be extremely difficult to access the retroperitoneum and the lateral aspect of the repair. When patients were supine, the incision was made either over the defect or at the midline. And when patients were in lateral decubitus, the incision was nearly always located laterally to provide optimal access to the retroperitoneum. When the medial edge of the defect was close to the midline, another incision may be made medially. In contrast, flank hernias with a concurrent midline defect were always repaired the same way, open, with the patient supine, and through a midline incision, sometimes with a counter incision over the flank defect to optimize the lateral aspect of the repair. The most frequent complications were surgical site occurrences, of which 5 required an intervention. 1 additional patient required reoperation in the 30-day postoperative window for an early recurrence. Patients were followed clinically for a median of 11.4 months, over which time there were 3 additional recurrences. Patient-reported outcomes were collected for 62 patients at a median of 30 months. During this time, 23 patients reported a bulge on their most recent PRO. The composite recurrence rate was 12 and included the 4 known clinical recurrences and 8 patient-reported bulges with no subsequent clinical evaluation. We measured quality of life using patient-reported Hercules scores. While there was no change in quality of life at 30 days post-op, there was a progressive and significant improvement in the median and paired scores reported by individual patients at 1 year plus after surgery. We saw a similar trend with patient-reported PROMIS 3A pain scores. The median pain scores decreased at 1 year plus after surgery, including a higher proportion of patients reporting lower than average and no pain. And individual patients also reported reductions in pain at 1 year plus after surgery. Based on these data, we developed an algorithm using preoperative hernia characteristics to guide the choice of operative approach, patient position, and incision location for flank hernia repair. This algorithm incorporates 3 questions. First, does the flank hernia have a midline component? Second, how wide is the flank defect? Third, how far is the medial edge of the defect from the midline? With regard to approach, for isolated defects that are less than 10 centimeters wide, we recommend either open or MIS repair. While for those larger than 10 centimeters, we recommend open repair. For flank hernias with a concurrent midline defect, we generally recommend open repair. However, MIS approaches may be suitable in some situations where the defect is small. With regard to positioning and incision location, for isolated defects within 12 centimeters of the midline, we recommend supine positioning and a midline incision to allow the mesh to be placed across the midline and in the contralateral retromuscular position, ensuring adequate medial coverage of the defect. For isolated defects 12 centimeters or more from the midline, we recommend lateral decubitus positioning and a lateral incision because it is much easier to gain access to the retroperitoneum. For flank hernias with a concurrent midline defect, we recommend supine positioning and a midline incision to ensure adequate medial coverage and exposure of the defect. And we recommend considering a counter incision to provide extra lateral exposure and coverage. While the thresholds we have identified in our algorithm are not hard and fast rules, this is a useful guide and a starting point for an ongoing discussion on strategies for flank hernia repair. Thank you for your time.
All right, thank you, Whitney. Oh, that's awesome. I love algorithms, and that I'm definitely going to take back with me and start using. I took a nice screenshot of that algorithm. I hope you guys publish that soon. So the next speaker is, sorry, I lost my list here. Let me pull it back up. All right, next speaker is Jeremy Warren, and of course he doesn't really need an introduction. He's at Prisma Health, and he is going to tell us about the high performers in peristomal hernia repairs. I didn't think there could be high performance in peristomal hernia repairs, but I guess there is. So I'm very interested in this talk. So Jeremy.
Hey, good afternoon, everybody. This is Jeremy Warren from Greenville, South Carolina. I can talk to you a bit about optimizing outcomes and approach for peristomal hernia repair. And I would like to point out initially that the program has an error in it. This says high performer, and I think I'm really just the only sucker who agreed to talk about peristomal hernias. So with that caveat in mind, I'll kind of jump right in. You know, an ostomy really by definition is a full thickness hernia defect of the abdominal wall that has bowel passing through it. I mean, that is a hernia. Clinically, these become apparent in at least 50% of patients, probably more if given enough time. And overall, our outcomes for repair are just not great. They are not as good as incisional hernias, which kind of makes sense because you can't really get rid of the hernia defect like you can for a typical incisional hernia repair. And as such, we really haven't identified the optimal repair technique. There's a lot of different options. And I'm going to go over several of these as we go. So I'm just going to kind of skip over this slide for now. But just to highlight the lack of clear direction in the literature, the European Hernia Society guidelines were published just a couple of years ago on the prevention and treatment of peristomal hernias. You know, this is a pretty thorough, systematic review of the literature on peristomal hernia repair. And, you know, the only thing to really take away from this slide is in the right-hand column that there is weak or no recommendation for almost everything. The only two exceptions to that are prophylactic mesh should be used at the site of a new end colostomy, and a permanent synthetic mesh is better for prevention of peristomal hernias, and that you should avoid suture repair alone of peristomal hernias. Everything else that we're going to talk about is still up in the air as far as optimal technique. There's just simply not enough evidence to clearly delineate which patients should get what repair and what repair might be best. So just kind of looking at my own practice here and our practice here at Prisma, if we can reverse the ostomy, I think that's the best type of peristomal hernia repair. If you can get rid of that residual abdominal wall defect by a complete reconstruction, that's ideal. Me personally, I've performed 83 of these cases of ostomy reversal with concurrent hernia repair. Most of those do involve a transversus abdominis release because usually that peristomal defect is going to encroach on the semilunar line and you're going to need some additional mesh overlap there. One patient was repaired with an absorbable synthetic mesh and one was repaired primarily due to some intra-abdominal complications. But for the most part, we use a permanent synthetic mesh for these repairs. And our OR times, as expected, would be fairly long. These are fairly difficult cases when you're combining procedures like this. Average length of stay of 6 days, infection rate of 14.5%, with other wound complications occurring in just under 20%. One patient did require mesh removal for infection, but overall, that's a pretty rare occurrence in our practice. Recurrence rate is 1.2% for peristomal or incisional hernia recurrence. Caveat to that is our long-term follow-up is admittedly not great. So kind of keep that in mind with any of the recurrence rates that I'll quote you today. We looked at this a couple of years ago of our overall practice and actually compared that to ostomy reversal without mesh reinforcement. We found that the SSI and SSO rates were actually almost identical between the mesh and non-mesh groups at about 20% each. In the mesh group, we did have 5 patients that required removal, though none of those were for primarily a mesh-related complication. They were all for intra-abdominal complications that required a relaparotomy for intra-abdominal sepsis. And we found a pretty low rate of development of stoma site hernia recurrence and midline hernia recurrence with this approach. When the ostomy is not reversible, there's a few different approaches to think about. So I've done 29 open peristomal hernia repairs. Most of these are done in a retromuscular fashion using a keyhole technique. A handful of IPOMs and onlays and no mesh repairs, but very few. And I've more recently gone to doing some of the tar sugar baker repairs. I personally have done 7 of those in an open fashion. Often what I find is that the mobilization of the bowel is what the real limiting factor in making that decision between a keyhole and sugar baker is. But in any event, I think the keyhole technique open in a retromuscular fashion does not necessarily have a higher recurrence rate than a sugar baker. I think that's pretty clear in the laparoscopic literature. The keyhole does not perform as well, but that's not clear in the retromuscular repair literature. But it's also fairly limited. So in my hands, the open repair times are still pretty long. These are again very complex cases. Average length of stay of about 6 days, primarily waiting on bowel function. I've had 7% infection rate. 1 required a perk drain. None have required mesh removal, and then other wound complications in 24%. Often these are seromas or hematomas within the hernia sac. The recurrence rate is 10.3%. For MIS repairs, as you can see here, these can be done as a keyhole or a sugar baker approach as well. We've really never done any laparoscopic IPOM keyhole repairs. I think the literature is reasonably clear that this is not as good of a repair as a sugar baker when it's mesh in the intraperitoneal position. So I've had 2 of these done straight laparoscopically, both in a sugar baker fashion. 22 that were done robotically. 4 of those had an IPOM sugar baker, and the remainder were some sort of retromuscular repair, most of which included a tar, and most of which were done in the tar sugar baker approach. And that's what I want to highlight here with this brief video. So we've actually gone to doing most of our robotic retromuscular repairs using an ETEP approach. So fairly typical OR setup, depending on the shape and space of your OR and which robotic system you're on. But generally we'll place the trocars into the lateral rectus sheath opposite the side of the peristomal defect. Sometimes we'll go superiorly for the peristomal defects, but I think the lateral view is kind of nice for these peristomal defects. The initial entry is done with an optical trocar directly into the retromuscular space. Kind of blunt and pneumo dissection kind of opens up that space for you until you can get additional trocars in, and then just kind of keep carrying that dissection along until you can get additional trocars along that lateral rectus sheath, and you can bring the robot in at that point. then are going to do the crossover maneuver, incising the posterior rectus sheath just under the linea alba to get into that midline pre-peritoneal space. This is where any midline defects can be addressed, but also what makes it more complicated if there are midline defects, particularly if they're of any size, that can make this portion of the dissection and subsequent closure and reinforcement a bit more difficult. So that I think does limit this approach a little bit. Once you're across the midline, you're going to get into the retromuscular space on the contralateral side, the side of the stoma. I'm always going to open the hernia sac on one of these to really get in and make sure that you can immobilize the bowel, make sure that it's free from the hernia sac, make sure it's free from the surrounding viscera so that you're going to have adequate ability to lateralize that bowel and avoid any unnecessary redundancy or adhesion within the hernia sac itself that could, cause an obstruction or potentially undue tension and erosion. So now we need to get some lateral space created for mesh placement in the sugar baker portion of the procedure. So we're going to do a TAR, begin that above and below the stoma site, carry out that dissection pretty laterally, usually to about the mid to anterior axillary line. Let that posterior sheath drop down fairly flat across the viscera. And do that dissection above and below the hernia defect first, and then transverse there behind the ostomy. Having that space above and below makes it a lot easier to see and navigate that space directly lateral to the stoma. Once we have that space created, we'll go ahead and incise the posterior sheath straight lateral from the original posterior sheath defect where the ostomy is passing through. And that'll basically allow us to just take that bowel, lateralize it against that lateral abdominal wall, and recreate a new posterior orifice laterally. You can pexy the bowel up against the abdominal wall with an absorbable suture that can kind of help keep this out of your way a little bit while you're doing your posterior closure. Not necessary, I don't do that all the time, but it's been helpful at times. And then you're going to close up that posterior sheath, either medial to lateral or lateral to medial, it doesn't really matter. But this is where a assistant can very much help you keep that bowel lateralized while you're closing. Any anterior defect can be closed to snug that abdominal wall around your ostomy as well. Again, we use just a permanent synthetic mesh for this repair as well. You don't need a barrier coated mesh in this space. Lay that out underneath the bowel, lateral to the ostomy, good above superior, inferior, and medial overlap. Here I use transfascial sutures from percutaneously. Typically don't do that. I've done it a few times. Truthfully, hadn't settled on an optimal fixation technique at this point. I think that no fixation is probably not ideal. I've had several of these patients come back even fairly early and get CT scans that show that bowel to be fairly straight back through the abdominal wall instead of keeping that nice S shape underneath that lateral abdominal wall. That kind of indicates that this is falling down and kind of pulling some of that mesh medially, and you just don't have any mesh overlap laterally. So not a lot of clinical recurrence with that, but that worries me that we're going to start seeing that in the long run without some kind of lateral fixation. So again, these are fairly long, fairly complicated cases, but they do tend to go home a little bit faster, on average 4.6 days. Interestingly, the infection rate is not lower. So 20% of these developed an infection. 2 of those were patients who were converted from robotic to open, so they're pretty complex patients. And one of those required, complete resiting of his stoma. So it was a pretty complicated case. And one patient had a devascularization injury of the colon that presented post-op day 7 with perforation that required to take back to the OR and ostomy revision as well. Haven't had to remove any of the meshes despite some of these pretty big complications, though. Other wound complications primarily are seromas, hematomas in the hernia sac, and so far a recurrence rate of 8.3%, but again with pretty limited follow-up. And again, keeping with the EHS guidelines, I think prophylaxis really is key. So as much as possible, we are reinforcing new ostomies when they're created. We looked at our data as an institution a few years ago. We had 52 patients who received primary mesh reinforcement in the retromuscular space. One patient had to have their mesh removed which was not directly related to an infection, but an ostomy complication. 20% overall infection rate, most of which were not directly involving the mesh. They were, intra-abdominal abscess, things like that. Peristomal hernia incidence is 11.5% in that population with about a 2-year follow-up. So certainly better than 50+%. But we need better long-term follow-up to really kind of confirm those findings. In my own hands, I've done 35 of those cases, 8.5% incidence of peristomal hernia. So I still think this is probably the best way to go, but we do need better long-term follow-up to really hone in on those optimal results. So the overall approach is first determine the symptomatic status of the patient. If they are asymptomatic, if they're not having difficulty pouching, if they've not had problems with prolapse or obstruction or a lot of pain, then I really try to push watchful waiting on these patients if at all possible. These are just tough cases with suboptimal outcomes. Wait until they're having a meaningful improvement in their quality of life by fixing it. If they are symptomatic and reversible, then I would strongly encourage them to get the ostomy reversed and do a definitive hernia repair at the same time. But in those patients who are not candidates for reversal, but are also significantly symptomatic, we'll typically talk about the open or robotic retromuscular repairs and then the traditional lap or robotic sugar baker repair. So for me, I'll kind of start at the bottom. For a patient who's had a previous retromuscular repair of some kind, or that are, small to moderate sized defects at high risk for wound complications, I think a lap or a robotic sugar baker IPOM technique is actually a really good repair. For a robotic repair, I think it's limited by the morphology of the midline in particular. So a large midline incisional hernia or a really large peristomal hernia is going to be very difficult to repair robotically. And so those largest, most complex patients are typically going to get an open repair. So just to quickly summarize, these are always difficult cases. We really don't know the optimal repair. The jury is out on sugar baker versus keyhole when we're talking about the retromuscular space. And I think the jury is definitely still out on the robotic repair. There's still nothing wrong with just a good old lap sugar baker. The results of that are still pretty darn good. But prevention is key. If we can get to preventing these hernias at all, that's going to be ideal. Thank you.
Thank you, Jeremy. You're a high performer just for taking these on and having such a big toolbox with so many different options, which is awesome, and having a recurrence rate of way lower than 50%. So you're a high performer in my book. Unfortunately, we have just one more talk. It's going to be by Christopher Bailey from Austin Regional Clinic, Austin, Texas. He's going to talk about rectus diastasis repair. So Chris, take it over.
Hello, I'm Chris Bailey, a general surgeon from Austin, Texas. Apparently, I repair a lot of diastasis, always in conjunction with hernia repair, of course. Or at the very least, I always document when I see a diastasis and how I manage it in the database. A little about me. As you can see, I'm about 10 years out of training. I have no fellowship. The program I went to was very MIS dominant, however, and I was influenced by surgeons you are all likely familiar with from Greenville, South Carolina. I started my robotic career in November of 2016. First of all, diastasis recti is defined as a separation of the abdominal wall musculature at the midline and can occur above and below, but most commonly around the umbilicus. Diastasis is traditionally associated with pregnancy, but is seen in both males and females. It is most often seen in patients who have had or continue to have a period of weight gain or obesity, and it tends to run in the family. We as surgeons are finally starting to realize that the imbalance of core created by diastasis creates stress on the lower back as abdominal muscles are no longer in a vertical orientation. Interestingly, traditional risk factors for hernia recurrence overlap with risk factors for diastasis. Theoretically, diastasis is therefore an additional risk factor and should be addressed. Thinning of the linea alba results in additional hidden defects that can go unrecognized if not appropriately addressed. These can later reveal themselves as recurrences above or below the mesh. Additionally, this thin tissue is unreliable for mesh fixation and can be a site of recurrence. Failure to repair diastasis is a failure to address the full spectrum of hernia disease in the midline of the abdomen. It is therefore important to select a hernia repair technique that allows for intraoperative inspection and management of the diastasis, if present, in association with a hernia. It is for this reason I prefer the TAP and ETEP approaches above all others. Okay, pathway to surgery. I take 5 primary components into account when deciding upon my operative approach to ventral hernias. Assessment is based on exam preferably, but with CT, abdomen, and pelvis when necessary, but not routinely. I have found that CT scans often fall short in the identification of small asymptomatic defects associated with diastasis that will become a risk factor for recurrence years later. This is a busy slide, but important. These 5 components help me decide upon the best approach for hernia and diastasis management for each patient. I perform open repairs with primary defects 2 centimeters or less, no additional risk factors, no diastasis, and of course I also perform open repairs with large complicated defects. I no longer perform lap IPOMs secondary to good robot availability. Robotic IPOMs are used primarily as a bailout option when a TAP fails secondary to peritoneal defects, and also for off-midline hernias. Robotic TAPs are a good choice when adhesions are not expected, BMI is less than 30, defects are less than 5 centimeters, and the diastasis is limited. Robotic ETEPs are my favorite. They're a great choice when prior surgery or adhesions are expected, BMI is greater than 30, defects greater than 5 centimeters, when a TAR is possible, and also if there's a concomitant presence of an inguinal hernia. This is a summary slide of my technique for easy reference. I've been very consistent with both suture type and closure style over the past 2 years in order to generate consistent data. The videos I have playing are typical examples of 2 patients with a diastasis. It is important to understand that when you perform an IPOM, this poor tissue in the midline is hiding underneath the preperitoneal fat and is all that is standing between your repair and a recurrence. Approach is critical and requires a lot of forethought. It is extremely dependent upon body habitus and defect location. The lateral approach is my preferred, as you will have a successful repair in all body types and defect locations, including surprise defects that you were not expecting. You avoid placing any trocars in the midline where the disease is located. Double docking is required if a bilateral TAR is needed, but this is predictable preoperatively and can be planned for. I have performed all approaches many times and they all work. I have shown my placement guidelines here for reference with special details on the lateral approach. Naturally, I'm very particular about my suture. This is my favorite by far, and I've broken it only a handful of times. It is long and requires a lot of discipline secondary to memory. It only comes in one length, 45 centimeters or 18 inches. I follow the instructions on the Ethicon website for Stratifix anchoring, suturing, and securing. I always use this needle driver setup because they are stronger, wider, faster, and less likely to fracture the suture when used correctly. You also avoid shortening the life of the fenestrated bipolar, which will happen when using a CT1 needle. Start high and low, work your way towards the middle of the defect. 5 millimeter bites and advances. I do the entire operation between 8 and 10 millimeters of mercury insufflation pressure to facilitate closure, limit pain post-op, and decrease the incidence of crepitance. Burp your trocars as you go to relieve tension on the closure. Ensure capture of the juncture of the anterior and posterior midline rectus sheath layers with closure to ensure strength. Venetian blinds plication of the wide diastasis defects will flatten the repair, which would look like a visible ridge on the abdomen. Always use small bites and small advances. I believe that this is the most critical portion of closure, and failure to capture this junction for strength is the main reason why people have failure of their diastasis closure and also hernia defect closure, regardless of suture choice. Regardless of diastasis closure, we have to assume that this patient population is at higher risk for recurrence in the midline. Without coverage or reinforcement, you have violated a space that will be difficult to get back into, so take advantage of the opportunity to limit risks long-term by covering the entire midline with mesh. I fixate R-taps only with permanent suture. I do not fixate E-taps. I've been using polypropylene exclusively, but originally preferred Versatex, which was polyester, and had less memory prior to its recall for ventral hernia repair. Postoperatively, I get my patients moving quickly. The goal is what I call dynamic scarring. This ideally results in flexible scar tissue with fewer residual effects long-term. My patients who are most active early on seem to report the fewest complaints. I do share the ACHQC app with the patients and encourage the stretching and exercise guidelines within for my less motivated, typically inactive patients especially. These are questions that we need to answer going forward. They have serious implications and may ultimately determine why laparoscopic hernia repairs, for all but the most skilled, are difficult to compare to advanced robotic hernia repairs. In my opinion, we are currently comparing apples to oranges, and answering these questions will help us prove why. Make sure to document in the database every time a patient has a diastasis. Measure it and indicate how you managed it. This will help us all determine the true significance of diastasis. Lastly, there are many opportunities to advance your practice and understanding online. This is the way that ideas, data, trials, and techniques are being disseminated now, so participate. I'm available for contact if needed. I also perform case observations, so if you're interested, let me know.
That was a great presentation, and actually all the presentations are great. I learned a lot. So we'll go on to our panel session now with questions. We do have some questions that are on the answering questions and answer section that has not been addressed. And there is a questions that just appeared.
While you guys are doing that question real quick, first of all, great session. Thanks so much. Let's say we're running a little late. Why don't we let's do a 10-minute panel session, and then we'll kind of have a wrap up. Does that sound okay?
Sounds great.
Okay, we can go ahead and show the results of that question if you want there, Nicole or Aileen. Do you have the results of that? Or? Okay, spectacular.
That's great.
So there was, I see one question in the chat about opening the hernia sac safely. That video was the peristomal, obviously, but it applies broadly to any E-TEP approach. And that was one of our kind of initial apprehensions about going to ETAP from a transabdominal approach. And ultimately what you find is it's surprisingly easy most of the time to tell what's on the other side of the hernia sac. With the pneumo, the insufflation that you have in that space and your ability to see what that tissue is doing, it's usually not too hard to identify the correct plane and sharply incise the hernia sac to get in. That's assuming you didn't already accidentally get in just with normal dissection. So it's a little bit like any other open hernia repair. You always have to make some decision about where you're going to get into the hernia sac. You do that by feel, how it looks, your experience. And you're usually right, but every now and then there's an adhesion on the other side that you pay for. But I think it translates very well into that robotic space. So.
Yeah, Jeremy, I agree. When I do these, a lot of times I accidentally put a hole in the peritoneum, and it's one of those events where I'm happy that it happened, and usually it's while opening up the posterior rectus sheath and the peritoneum so thin it just kind of rips apart as you're opening it. So it's usually not a big deal. Now there was a question about coated, uncoated mesh for peristomal hernia repairs. That you kind of answered it, but you want to give us a little bit more thought about why you use uncoated, and aren't you worried about this uncoated mesh, 10, 20 years later, eroding into the bowel? Doesn't seem to be a higher rate with early results, but how about long-term?
Yeah, sure. I think it's definitely a potential concern in the long run, and we really don't have a lot of long-term data to answer that in general. Specific to peristomal, I think since I've been here in Greenville, among the three of us, we've seen maybe 3 to 4 cases of mesh erosion on a peristomal hernia, all of which were actually intraperitoneal meshes. We've seen a handful from other just laparoscopic hernia repairs and intercutaneous fistulas. We've probably actually seen about 40 to 50 of those. So those are barrier coated meshes in the intraperitoneal space, which is the vast majority of the actual bowel erosions that we've seen. I personally am not aware of any of our peristomal or retromuscular repairs that have had a mesh erosion, although it doesn't mean there's not any, it just means I'm not aware of them. So the patients that I'm very cautious on doing that with would be, a Crohn's patient, particularly with a fistulizing Crohn's disease. I'm usually not going to do a polypropylene sugar baker for that patient. They'll either get a keyhole or potentially an absorbable synthetic repair rather than the polypropylene. But that's more associated with patient disease, I think. I know, Mike, you guys have done a lot of these as well, and you're doing a trial now. So I know you've got some experience with that as well. I think to me, the hardest part is always getting the right level of tightness around that ostomy. That's one of the hardest parts of it, even more than just an inflammatory erosion. It's getting it the right tension where you don't obstruct. So.
Yeah, I think, we kind of say, basically, we suck at all para operations, peristomals, paraesophageal hernias. At the end of the day, when you have to do something that's kind of more of a physiologic operation, not make it too tight, but make it tight enough, the reality is you never leave the operating room that satisfied. And if you did, you probably did it wrong. So I think, for peristomals, we're doing a trial right now, keyhole versus sugar baker. So I don't know what the results ultimately will be, but they both have their limitations. You can make them both too tight. You can make them both too loose. We don't use coated mesh. We've had erosions with keyholes, and we've had erosions with sugar bakers as well. Not so much, I think, long-term because of the mesh, but I think you do need several years to kind of figure that out, but more so because we put some stitches or we made the hole too tighter. Actually, Dave Capata in our group, and I think this is the longest stretch we haven't had an erosion, we actually stopped putting any sutures in keyholes or sugar bakers because we felt like if you held the mesh in place when you put it and then they stand up and like their body and their stoma moves, you might do that. That's pretty anecdotal, but we're on a pretty long stretch, knock on wood. I'm sure next week it'll come back. But yeah, I think these things are tough. There's no easy way to do it. open robotic lap, they're all challenging. And it's basically just getting that architecture right to make it happen. So there's a lot of unanswered questions with peristomals.
I have a questions about whether people actually use maybe put a Foley catheter for the urostomy, because sometimes you can really restrict that. And I unfortunately have to admit that I have a patient who got into trouble after discharge from the hospital and got kind of a little bit of a kidney injury from obstruction and didn't realize it just over 12 hours. So from that point on, I have always kind of kept a red rubber catheter in the urostomy. Is that what other people are doing?
We do a lot of those. Just a couple little quick hints about it. Number one, you always got to remember, if they have a urostomy, then their ureteral orifices are wide open. So they're very susceptible to obstruction and hydro, not like somebody with a bladder. So, and typically these people, because they have bladder cancer, tend to be older, tend to have some baseline renal insufficiency. So a couple of things, I actually put a Foley and I blow the balloon up to like 5 cc so that I know where it is. And sometimes it's easier to figure out which is the right piece of bile when you do that. I don't do that for colostomies, but for urostomies I do. And then I think the most important thing, whether you do a keyhole or a sugar baker, is get the tip of that Foley past your mesh before you stop, because they are prone to that. And when it happens, again, like just as a trick, because it happens every once in a while for us, if you have trouble getting the Foley because it's a little bit swollen or edematous, just put PERT nephrostomies in. You put bilateral PERT nephrostomies. You don't have to mess with the mesh. And you can just sit tight. It's a little bit nerve-wracking. It'll make you a little bit uncomfortable. But most of the time, if you just wait that out, it's like early post-op dysphagia after a Nissen. If you can just bypass it, you'll be okay. Now, if you think you got an erosion or something, that's a different story. But yeah, it happens. And I mean, it happens frequently.
Thank you. Looks like there's another question about intraperitoneal hernia with ETAP. Anybody want to answer that? How to mitigate this problem, this from happening?
So I think the most important thing is, and this happens as you do more of them, and I certainly would defer to some of the other panelists for their opinion as well, but if you're having to work to get the posterior sheath closed at a pressure of 12 to 13, then you most likely need to do something else, either a release or some type of maneuver. But I'd say really, as you do more of these, you get a sense of how tight that visceral sac closure is. And when in doubt, release more.
And we've seen that with every version of retromuscular repair, not just ETAP. So it's not unique to the ETAP repair by any means. We've seen it in about 1% of our patients. And that is actually one of the really nice things about the ETAP approach, is it does give you the ability to sort of stepwise add some additional release. And you may not need much. You may not need to do a TAR. You may just be able to incise that posterior lamina of the internal oblique and get an extra centimeter for closure. The more the peritoneum you're able to save, you can often, not have to close much at all. So it can happen with any of those approaches.
Yeah, I agree. That just never reapproximate the posterior rectus sheath if you're not performing a TAR. I would say you can be fooled thinking that it can come together, but it'll fall apart later. And I try very hard to maintain the peritoneum or save the sac, or even take down some of the pseudo sac if there's a lot of subcutaneous tissue, to use as my posterior barrier. And a mini TAR, just cut the posterior rectus sheath at the arcuate line. Sometimes you just cut it a few centimeters and you get enough release with inguinal dissection. You get enough peritoneum and bladder mobilized. You can close the posterior layer pretty easily.
It's great. Maybe just a last comment on the patient education with you. That was great, using the Oracle. And also, somebody else also talked about using the app. I love the app. I have every single patient download the app, and it's very useful. And I have the physical therapist in the hospital work with them. And I find that very, very helpful. And thank you for QC for providing us with that.
All right, guys. Well, listen, just a couple quick announcements. First of all, I just want to say thanks to everybody. We had a tremendous turnout for virtual. I know it's a tough day to sit here in front of your computer. So I just want to congratulate all the moderators, all the panelists, and everybody, for just believing in quality and believing in collaboration and doing this. I look forward to when we can all meet together in person for sure next year. I want to just take a second and announce our winner for our ACHQC grant. Just to let you all know, it was incredibly competitive this year. We actually had 13 tremendous applications. They were all reviewed by 3 judges in a blinded fashion. It was extremely competitive. But I'd like to announce that Colin DeLong from Penn State Hershey was actually the winner. I don't know. Colin was on a very busy trauma service, I think, right now. So I wasn't sure if he could actually be there. But congratulations. Eric Paula and Charlotte Horn are his mentors. It was a project looking at whether or not geographic location influences access to patient care. So congratulations to Colin on that. And again, thank you all. I just want to stress, so we're not over yet. There's 2 options left to go for our happy hour. There is a Peloton ride for fun, for enjoyment, to try and kill each other, whatever you want it to be. It'll be there for you. You make the QC what you want. Nicole sent an email about it. We're going to start, we'll say at 4:30, so everyone has a few minutes to get dressed and everything. If you don't want to come on that, then feel free to join the Zoom link on that email. It'll be the screen of the Peloton. You guys can chat, you can talk about things, you can ask more questions to some of the panelists and whatnot. Ben will be moderating that. But again, I want to thank everybody. I want to specifically thank Nicole and Aileen. They put this together. They really did a phenomenal job. I just have to say, the company that was going to charge us to do this was like $20,000, and they did it on their own back and put it together. So really spectacular. It was absolutely flawless. Congratulations. We're giving you a virtual applause for doing that. So thank you all. We will see you all in about 8 minutes. If not, on the app. My Peloton name is Watt, WATTTF. So if you want to cheer for me, feel free to cheer for me. Otherwise, I look forward to seeing you guys all in person. Ben, any other final comments?
Yeah, thanks everybody. This is fantastic, and I appreciate your dedication on Saturday. All I can say is I already worked out this morning. Got my little scotch ready. Rosa, let's see what you're made of. All right, let's go.
Let's go.
I'm with Ben.